In this event, just refreshments before we start the event. We have Athanasios Nikolopoulos to honor us. We are shadowing the event for 20 minutes from now. And we have the pleasure to start the event with Gabriel Diaz from Brazil. He's going to sing and give us a gift of nice, interesting musics. Thank you very much, Gabriel, and welcome.
Good morning, doctor. It's a pleasure for me to open this beautiful event, Retinawesome. And my name is Gabriel Diaz, and I'm from Brazil. And I will sing the songs from Brazil and around the world. I hope you enjoy. Good morning and good luck to everybody this morning. Tristeza sem ela diz uma prece que ela regresse, que eu não posso mais sofrer. Chega de saudade, realidade que sem ela faz uma beleza é só tristeza e a melancolia e não sai de mim, não sai de mim, não sai. Tristeza de desarme sem ela pode ser diz uma prece que ela regresse, porque eu não posso mais sofrer. Cheio de saudade, realidade que sem ela não há paz, não há beleza, só tristeza e a melancolia que não sai de mim, não sai de mim, não sai. Hello. Hello, good morning.
Bom dia, Gabriel.
Você consegue me ouvir?
Estamos te ouvindo. Liga o áudio original do seu celular para a gente ouvir melhor.
Aonde?
Tá legal, pode continuar.
Consegue me ouvir?
Sim, perfeitamente.
Well, the first song was a song by João Gilberto from Brazil, but I didn't finish. But I will pass from the next song from Louis Armstrong. As streams of green, red roses too, see them blue for me and you, and I think to myself, what a wonderful world. I see skies of blue and clouds of white, the bright blessed day, the dark sacred night, and I think to myself, what a wonderful world. The colors of the rainbow, so pretty in the sky, are also on the faces of people going by. As a friend shaking hands, saying, how do you do? They are really saying, I love you. I heard babies cry, watch them grow. They'll learn much more, and I never know when I think to myself, what a wonderful world. Yes, think to myself, what a wonderful world. Que sea tan lenta la canción, que se detenga mi reloj, que haga una pausa sin razón, el tiempo, que la manzana deje de caer, y el viento de correr, que la lluvia deje de llover, antes de tocar el suelo. Por hoy seremos tú y yo, dos personajes de ficción que saben cómo escribir su propio cuento. 4 paredes nada más, el escenario principal es el lugar donde la pura realidad es la misma que los sueños. Sabemos perder la mañana, perdidos en la habitación, fingiendo que el día no pasa. Vamos de nuevo, ganando el tiempo. No hay nada mejor que hacer nada. No importa si hay tanto que hacer, dejémoslo para mañana. Y así, mañana, de dejarlo otra vez. Poder dejarlo otra vez. Poder dejarlo otra vez. Poder dejarlo otra vez.
Liguei.
This song is kind of jazz.
Jazz from which
From the
country
the-
is this?
the band Fat Fat from Spain and Jorge Drexler, a composer and musician from Uruguay, but
Uruguay. Yeah, very good.
he's living in Spain.
You are
Can
you are
listen me clear and
Yeah, you are broadcasting from the cell phone or from the computer?
the cell phone?
Yeah. If you se você colocar para cima, if you go up, you are gonna see como chama?
Yes.
Som original, som original. De som original evita os ruídos, aí fica ele melhora muito o som, colocar o som original. Se você colocar assim para cima, tem a opção som original, porque senão ele fica uma hora, ele mostra o som do violão e a outra hora o som da sua voz. Entendeu? É o que o Regis estava tentando explicar. Tenta fazer isso, colocar no celular, subindo, né, Regis? Na abinha de baixo, pelo celular. Aí você coloca original sound, som original. Aí a sua voz fica melhor para você falar sem competir com um som, sai uma hora a viola e a outra a voz, né? Então fica tudo ao mesmo tempo.
Certo.
Tenta encontrar. No computador é um lugar diferente, no celular é só levantar a abinha. A lot better.
Okay. Let's go.
Yeah, it's
A
much
bossa
better.
from Vinícius de Moraes.
Vinícius de Moraes, Brazilian singer, very famous. Yeah, I love Vinícius de Moraes. Go ahead. Yeah, great.
E por falar em saudade, onde anda você? Onde andam seus olhos que a gente não vê? Onde anda esse corpo que me deixou morto de tanto prazer? E por falar em beleza, onde anda a canção que se ouvia nas noites dos mares então? Onde a gente ficava, onde a gente se amava em total solidão. Hoje eu saio na noite vazia, numa boemia, sem razão de ser, a rotina dos bares, que apesar dos pesares me trazem você. E por falar em paixão, em razão de viver, você bem que podia me aparecer nesses mesmos lugares, nas noites dos bares, onde anda você? E por falar em saudade, onde anda você? Onde andam seus olhos que a gente não vê? Onde anda esse corpo que me deixou louco de tanto prazer? Hoje eu saio na noite vazia, numa boemia, sem razão de ser, a rotina dos bares, que apesar dos pesares me trazem você. E por falar em paixão, em razão de viver, você bem que podia e aparecer nesses mesmos lugares, nas noites dos bares, onde anda você. Você. And now, Edith Piaf. Non, rien de rien. Non, je ne regrette rien. Il est bien, on m'en fait. Il est mal, j'en ai bien les gars. Et non, rien de rien. Non, je ne regrette rien. C'est payé, balayé, oublié. Je me fous du passé avec mes souvenirs. J'ai allumé le feu, les chagrins, les plaisirs. Je n'ai plus besoin d'aller mes amours avec les trémolos. Allez pour toujours, j'ai repassé. Non, rien de rien. Non, je ne regrette rien. Il est bien, on m'a fait. Il est mal, j'en ai bien des gars. Non, rien. Je ne regrette rien, car ma vie, car ma joie, aujourd'hui, ça commence avec toi. Ça commence avec toi.
Escutando? Can you hear me? Gabriel.
Now, yes.
Yeah, very
Now I
good.
can-
Yeah. Yeah, thank you very much for your participation. And I want to welcome you all to the Retinawesome number 9. I want to welcome Dr. Natarajan, Dr. David Shaw, speakers, and Dr. Athanasios Nikolopoulos, who are there already. Thank you very much for your participation, and everybody else. And people are going to come in and join us. And it's an honor to be here. We're going to wait for more 5 minutes to go because the event is set for 9 a.m. here, Brazilian time. It's 2 hours less in the US, Eastern time. And what time is it, Athanasios, in Greece, Athens? Are you in Athens?
Yes, I know I'm in Thessaloniki, and now it's about 3 o'clock at noon.
Yeah, Thessaloniki, okay. Yeah,
It's
I asked before.
lunchtime. It's 3 o'clock
morning,
at noon.
Yeah,
Good
great
morning,
place,
Athens.
great place, Thessaloniki.
Hi, my friend.
Okay, and hi, David Shaw. How are you doing?
Hi, Hudson. Can you hear me?
Hi,
Morning.
Natarajan. Good morning. Good morning, David. Good morning, Natarajan.
Yes.
David, I read in the Star. I read it every day because I miss my good times in Toronto, and cases of COVID are soaring in Ontario in general, and I've been watching some lives from the Mayo as well, and things are pretty much similar to here, and I think in many places in the world. And do you think things are going to settle down for the next few weeks?
Well, I think they are because they've put us into the worst lockdown we've had since this started. So I think the public here is pretty angry this week because the politicians have I think the public's tolerance and patience of what's been going on is disappearing. And I think you're seeing it play out now here in Toronto for the first time. I noticed last night there's a lot of pushback, and now they're starting to advocate. Well, not advocate. The mayor, for the first time, is allowing the police to do random pullovers to check why you're out and about and things like that. So some of the civil liberties that are now being removed are not going over well. So we didn't go through this last year. We never had that level of restriction, but I think our government is just kind of trying to figure out how to deal with a scenario where we do look like our ICUs are overwhelmed now. So they're setting up the military barracks, and they've canceled elective surgery. They've canceled now again elective visits to the office. So I think in response to the overwhelming numbers, and then it's all because of the variant, so the variants are really throwing a kicker into the whole story. And I think the underlying problem for us has been vaccine delivery. Like so much of the world, if you don't make the vaccine in your own country, you're desperately hoping somebody's going to ship it to you, and enough of it to get your population up to some level of immunity. And we've been struggling. Every day you turn on and you listen to 500,000 doses are delayed or not showing up for another week or 2 weeks or 3 weeks. And So that's the underlying problem here. The pharma companies, I think, are just so struggling to get everybody in the world the vaccine doses everybody wants yesterday that it's the underlying issue, you know. So if we were all vaccinated, this third wave here in Toronto would never have happened. And I think the public knows that, and the public feels like they've done everything they could for over a year now. And now we're getting hit with a level of infections here that's triple what we ever had. So it's tiresome, and tolerance is gone here, I think.
Yeah, I understand. It's a little bit like that here too, and I guess in India as well. I've been listening to news. Natarajan, how is it going in Mumbai, in your area?
We are in lockdown from last 2 days. It's quite bad in India, and I actually operated today, but still the patients are very few, and I think it's about only 10 to 20% of patients coming. We are again back to a lot of like restrictions, and it's going to extend up to 30th April. We have shortage of vaccine, we have shortage of oxygen, we have shortage of remdesivir. So it's suddenly, I think, in between, I think India enjoyed from January like something like it was a normal time. But I think probably they overdid. And then now I think it's a big problem. I hope this will be solved. And everywhere they're talking about break the chain. I hope we can break the chain so that because of the variant. And young people are getting affected. It's real sad. I hope we'll overcome it.
Yeah, we will. It's a matter of time. And
my own brother got COVID in Madras. He is now back out of the ICU, and also he is no oxygen. And his wife also was in the ventilator, but now on oxygen support.
Yeah, we had this shortage of oxygen here in Brazil, especially in the Amazon area as well. But things are going on the way to control, and we are getting more vaccines tested here and approved for emergency use. So things should be better. You know, I got my first dosing of AstraZeneca, waiting for the second one, and so I think with good time, we're going to get a good vaccination, and people are going to be cool, we hope. And
yes.
What about Athanasios in our area, the COVID?
Well, we have a double image of the whole situation. In the big cities like Thessaloniki and Athens, we have a mutation of this coronavirus that is hitting us very hard. We had a lot of people, and especially the health system cannot help the way that we want. We have 800 people incubated in the hospitals. The hospitals are full completely. But the nice thing, the other side of the story, is that we had, through the EU, we had a lot of vaccines, especially the Pfizer one. And all the health distributors, all the health employees have been already vaccinated twice. So from one side, the medical profession and everybody is vaccinated. Now they will try to vaccinate the rest of them. So we are about 10 million people altogether in Greece. Already 2 million have been vaccinated already.
Morning.
And the next good thing is that we have thousands of islands, touristic islands, and due to the government, they say that every island that has 1,000 people living there, they should be vaccinated altogether. So we have vaccinated all the small islands altogether, because if you happen to a small island, like in the Amazon, for example, you don't have the facilities to help them. So they already vaccinated the islands, because in Greece, you know, we live from tourists also. Tourist industry is very heavy in Greece. And we have to open sometime. But I think it's going to be a late summer, this summer. It's a very difficult situation in the big cities.
Yeah, I understand. And so,
especially young people. This is the more important. Young people didn't care before, and now the new mutation is getting to 30 years old, 25 years old, everybody.
yeah, the new mutation variants here as well in Brazil, we got it very strong. So they say that for the youngsters, these mutations, these variants are more, dangerous. So I want to welcome you all to Retinawesome number 9. It's a great honor to have you here. We're going to start the event. It's 9:03. Dr. Lam just said he's going to be in quite a while, in 10 minutes. And I see here also Dr. Sasamoto just got in here from Bolivia. And André Jucá, our keynote speaker, who gave us an honor to participate as Natarajan and Sasamoto since the beginning of Retinawesome. It's an honor to be here because, Retinawesome event started with us friends, and it's very good to be with you here, and I really appreciate Gabriel singing for us in different languages, and I appreciate Dr. David Shaw to having accepted participating into our Retinawesome meeting again. I'm very grateful to have Dr. Shaw, Dr. Lam, and we had before Dr. Divini in the past showing us some techniques, and they were with me in Toronto. Actually, I was with them. It was an honor for me, and when I see you guys, we get very thankful. So welcome, Dr. Lam. Good morning, Hong Kong. How is it going there? Everything fine?
It's good. It's good. It's 8 o'clock at night.
So I'm gonna show you a small video from. May I here share to participants and. Let me show you this video from. Can you see the screen?
No.
Not yet?
Just you.
Yeah. Regis, eu não posso ver compartilhar. Você pode dar pulinho aqui?
Oi.
Nossa, tá cheio.
Only host all participants. I want to share my. Eu quero mostrar. Share my screen.
Rede médicos, Maria.
Hi.
Good friends, George, Mitre, and Thanasis.
Good.
Yes, we are good friends for a long time. Remember when we meet the meeting in Belgium?
Yes, yes.
We are very young. We
Correct.
were very young on that time.
That's what I meant by telling my good friends. I didn't want to say old friends, George and Thanasis. Only thing is, I'm growing younger, and you both are growing with a lot of wisdom. I've colored my hair.
Lembra desse indiano?
So let me show you this video from the foundation here, welcoming you all.
O famoso.
There's no sound.
Yeah, we can't hear him. I saw the video yesterday, but you have to show the people. George, still there. Do you have the football court and the football
I hope
ground,
you receive
George?
this opportunity to discuss and learn more about this wonderful world
Yeah,
of the
that's it. So this is Zander from the iBank Foundation here in Brazil. He's welcoming you all for the event.
Good morning, everybody. As president of the Goiás iBank Foundation in Brazil, I would like to welcome the participants of the 9th edition of the Retinawesome that is celebrated the first year in Brazil, Hong Kong, India, Arabia, Canada, Bolivia, Greece, and all other participant countries. I hope you receive this opportunity to discuss and learn more about this wonderful world of the retina. I have a good meeting, a productive discussion, and an excellent day for everyone. On behalf of the Goiás iBank Foundation, I greet the coordinator of this project, Dr. Hudson Nakamura, who, with the permanent work, has been offering excellent results to our community. Thank you very much.
So these are the words from Zander from the iBank Foundation. And we are pleased again to have you here for this great event. Let me just share with you again our teaser, and then we're gonna come up with André Jucá for his words as a keynote speaker. Quero. Aí você. Ok. Can you share? Yes. Okay, so the small teaser for this presentation before we start the program with André Jucá, keynote speaker. Welcome, Javier. Thank you very much. And okay. So, André Jucá, it's an honor to have you. As I said, since the beginning of Retinawesome, you are with us. It's always an honor. You are the first Brazilian to be here as a keynote speaker. And we know for quite a long time of your great techniques in vitreoretinal surgery, your past and your fellowship that you did also in France as well, and then the good teaching that you spread to us here in Brazil, in the world. So it's a very honor to have you here, and I would like to have you share your content, and also before you show your case, you tell us anything you want on the world of retina, on COVID or anything, and feel home. So the word is yours.
Thank you very much for the nice words, Hudson. It's really a pleasure to be here with all you. I have learned a lot since the first edition from our colleagues all around the world. I just brought some ideas that we are developing in this field of fixation IOL to share with you today and perhaps to have some insights on it. So I'm going to share my screen and to begin. If you want to interrupt and say something, would be also nice. Can you see my screen?
Yes, pretty good.
Okay. Just okay. Thank you once again. It's a great honor, Hudson. I just brought this theme. The theme is adjustable 6-0 Proline flange technique, scleral fixation. We know there is many options of IOL implantation in absence of capsular support. We have done all. We have done anterior chambers, fixating posterior chambers, IOL to iris, through sutures or through some IOLs like Artisan, transscleral suture posterior chamber IOL, like the very much loved Gore-Tex technique that we use with aqueous intraocular lens, and the intrascleral fixation. We are going to talk today more about intrascleral fixation techniques. Indeed, the first report was done by Scariot in 2007, and 2008 the glue technique came with Agarwat, first publication, and it was really with Yemen that a major breakthrough came from using the optics of the free pieces intraocular lens to put it to fixate it directly on the scleral wall. Canabrava, a Brazilian guy, used a technique with 6-0 Proline to fixate without anything else, and Asia used it a more simpler technique that we use to just modify a little bit, and because this case was different from the previous Asia described cases. We have some references here that we can, if you're interested, see. And we did this case. This case was a 72-year patient that had a vasectomy in 2013 and a vitrectomy for retinal detachment in 2015. He had a very good visual acuity, but he has a capsular bag luxation. And here we are just with the lens in the anterior chamber. It's a vitrectomy side eye. And we were thinking about changing this lens because, as you can see, it's an Alcon one-piece lens. And we decided to just perforate the lens near the edge between the optic and the optic zone. We just did that, and we are just using this Proline 6-0 as a new optic to just facilitate things. Maybe this was our first case, so we are just improving the technique. Maybe it's a little longer, the the pro lane here. We should cut a little more. But anyway, we got it. You just use a 27 gauge needle to just go through the sclera. And then you do just the same with the other haptic. Now you have security, you see, and you do just the same with the other haptic. And we just pull it and again the flange, and then cut it, and then again over the needle. This was not a drop lens, was a drop capsular bag. So we have to fixate it. We could remove, put another lens, many options, but we just try to do that because in that case, you don't have to have a biometry. You don't have to have an intraocular lens. You don't. Sometimes this happens during surgical procedure, and it's nice not to having prepared for this. Just the 6-0 lens, very cheap, and then you just put the lens, and now, and the nice trick that you don't have with other techniques is just you can adjust the length. You just can pull it, and that's it. That's done. Interesting. You can do this technique with. Just go ahead. Yeah, with any kind of lens. We just did that with an hydrophilic intraocular lens to show how secure it really is. We try to do in the haptic instead of the junction. It works very nice as well. You just, there is some small trick. We do it at 2.5 millimeter from the limbus to avoid the intraocular lens touching the iris. So a little bit back instead of 2.5. We think it's you see how strong is that? We really pull, we cannot tear it. It's really interesting. Of course, 2 points may not be the ideal, but you can also use more. You can use even 4 points of fixation. It's not a problem. But do you think that 2 points may be enough? So there is some advantages. This technique is suitable for hydrophilic, hydrophobic, silicone, any kind of intraocular lens. It's suitable for 3 pieces and 1 piece as well. It's a quick procedure, as you can see. You do not have to do peritomy or scleral flaps, and there is no risk of haptic damage, of course. But the most important thing I think is you can adjust the length of the suture. So there is some key points. You must be sure that you are 205 millimeters and 180 degrees. And you can use a toric marker for that. But there is also some advantages, potential advantages. There is this uveitic glaucoma ephemeral syndrome, but you can avoid that if you are, I think, you are a little bit back, 2.5 millimeters. There is also the possibility of conjunctival erosion, so you must bury it under the tin. And of course, this has the potential of endophthalmitis. So you have to follow the patient for long term. The tilted of the IOL is also a possibility because you are fixating only 2 points. But we have seen on Asia papers that this tilt was really not important, about 2.5 degrees only. And of course, we have to follow up to verify long-term stability. We have heard that ProLine is biodegradable, but only 10 old ProLine will have this problem, I think. This is a very thick 6-0 propylene. It's not biodegradable in a lifetime, I think. Okay, thank you for your attention. It's just a small trick for this for IOL fixation. It has really a lot of options nowadays, and I'm just looking for the simpler and cheapest and easier one to do. Thank you very much for your attention.
Great cases and a different and fancy technique from you. And I do these regular ways of square fixation, but I would like to comment, to have the comment from Dr. Lam, and then Dr. Shao, and then Dr. Marcelo Murilo Sassamoto. But first, Dr. Lam, do you always perform, the secondary implants, and what are your comments on the Jucas case?
Yeah, I think first of all, congratulate Dr. Juca for showing the wonderful techniques. It's not always easy to do those scroll fixation, especially when you use a technique than what you used to. I think the 6-O-Polin definitely is a much stronger suture that will have the longevity compared to the 10-O-Polin that might break over time. So I think, as you said, the 2-point fixations has the disadvantage of having maybe a tilt that may occur. And so I think you've done a beautiful job in showing how the technique can be done. Just that I think you just make it look easy because it's not always so easy to do. And the advantage, I guess, is that you don't need to expand the implant, and you don't have to create a larger wound, so you can still manage with the smaller wound that's there. So I too like to kind of fixate the dislocated implant without having to exchange to a different one. But I haven't done this 6-O-Polin with the technique that you show. I still kind of use the 10-O-Polin, but using a fixation with the wider sutures apart so that they don't rotate as much. So, but very good techniques.
Great.
May I ask something?
Sure.
That means that you don't need the haptics anymore.
Yes.
You're just using the body of the lens.
Yes.
So in many cases, when we want to do a haptic unsutured through the sclerotomy and put it outside, while we're pulling the haptic outside, we might end up breaking the haptic or bending the haptic because the haptics are not made to be pulled by forceps that are not specially made for that. So it would be a very nice method. I didn't understand it fully, and I would like to send me the video just to study it myself. It was too quick, your surgery, and I missed it. But my idea is if you can use it as a secondary procedure, if you try to use the haptic suturing or the haptic whatever, and you damage the haptics, you can have an escape route with your system, with your style. And that's a great forward step because I've seen a lot of fellows destroying haptics while they try to pull something out of the sclera.
Yeah, that happens with the Yamane technique a lot. Yeah, we have seen that a lot.
So it's an escape route if you destroy haptics.
Yes.
You gave us another option, which is fantastic.
Yeah.
But Andre, that won't really work for most of the scenarios where we're trying to do the 3-piece, right? Because that's a PMMA lens. You can't you're passing this suture through a PMMA lens?
Yes, it's a PMMA. Yes, this is Alcon WF lens. It goes really very easily from any kind of lens except the old non-foldable PMN. But any kind of lens, I tested it. I thought in the hydrophilic it may tear it, but no, you see. But any kind of lenses go. I did it with the lens inside the eye. Of course, in a fake patient, you can do it outside the eye. It has been published on a site of the American Academy. Asia showed it. And this is a little bit trickier because the lens is already inside the eye. And I just thought maybe I'm going to use it to fixate instead of removing the lens, doing it inside the eye. So you just do 2 paracenteses and just the needle go very easily through the lens. This is Alcon, I think, the old WF model lens that have this yellow coat. Yeah, it's going very, very easily.
I was going to say, I think the silicone IOLs, it doesn't surprise me at all that the needle pass that you did, very creative. I love your idea there. I'm not sure I would have been brave enough to believe that suture would hold the IOL long term. So I credit you for having the bravery to do that. I don't know where you saw this or if this was your idea, but I'm certainly curious long term to see how stable that stitch will remain by melting it onto the surface of the optic. The biggest advantage, one of the other advantages is that for those of us that do Yamane, that second pass of the haptic is far more tricky because you have the inherent issues with the angulation of the haptic. So with a suture, which is what you're doing here, it's going to be much, much easier to pass a suture in any direction you want to dock it into the second needle. What needle were you using there, by the way? I didn't see that part.
Yeah, it's a round needle it's the needle that comes with it. It's Surgiprolan.
What size? 30 gauge?
The needle? No,
The needle.
The needle is 40 gauge because we are passing through it. Yeah. No, the needle is not 40 gauge. The needle is a little thicker. It's 27 gauge. Yes.
So, but I was going to say a 27 gauge needle track with a 6.0 Prolene suture. So I don't know what the diameter of a 6.0 Prolene suture is, but I guess that would be what my inherent fear would be, is that the needle track would be again too big and that suture could just kind of slide through the sclerotomy. All right. I don't know if you looked up those numbers to see what the size of a 6.0 Prolene suture is.
Yeah, but the needle doesn't go through the sclera. It goes through the lens and then through the paracentesis.
But I'm talking about you pass the thread through it, right? That's how you're externalizing the.
Through the paracentesis. I have a paracentesis, and the needle doesn't go through anything really, just any tissue. But so I captured the 6.0 Prolene with a 27 gauge needle. I think you could try to get it with 30 gauge needle. But anyway, you have a so big flange that it's not going to. But one big advantage is it's easier, like you told, than the haptic that can break, and usually is the second haptic that break in the Yamane technique. But it's not that. You have another thing that you can adjust, tight it, just make it much easier to adjust the intraocular lens because you have this unbreakable. I just try to show it's really unbreakable. I don't think it's going to break on long run, but you're sure we have to see it. I just saw a video just trying to break it. I think it's almost unbreakable. I just put a lot of force. I don't think it's really hard to break. I couldn't get it.
I think the main problem really is the possible rotations, because you have 2 single sutures on the optic, and if you have an extra suture that can keep it from the tilting, then it will be much more secure.
Yeah, you are right. With only 2 points, the IOL can tilt. But you can do that with 4 points as well. You can do 2 extra, but we thought it was not necessary. And it has been published by Asia in Cataract Refractive Surgery Journal, and in October 2020. I put the reference over there that he'd done some cases, not exactly with this technique, because the lens was outside the eye and he put it, was a fake patient. It was not like that, but exactly like that. But it was only 2-point fixation. And the tilt was really modest, just 2.5 degrees, and it's just very acceptable. This very small tilt.
Very cool. And last comment on this case is Dr. Marcelo Murilo Sasamoto. I think he's got a schedule now for emergency surgery. Are you there, Marcelo?
Yes, Hudson. Well, my comment will be actually the objective to cover the optics, or in this case the Prolene, I think is the best possible way to offering a patient a healthy go through. But I saw some papers that mentioned that Prolene probably is going to last like 10 years at least. So maybe I would consider that situation.
Yeah, but most of the patients, Marcelo, was done in not 6-0 Prolene, it was 10-0 or 9-0 Prolene. The 6 so thick that I think it would take much longer time to build the graphite. It's like it's almost like the thick of the optic of a 3 pieces intraocular lens. It looks like
same size.
Yeah.
All right. Thank you, André Jucá, for your case. And I also want to comment that, you know, that we are here between friends, among friends. And I remember, I think it was 2015 that you and Dr. Liri organized the Brazilian Vitreoretinal Society meeting as well. Wasn't it? Wasn't that year?
Yeah, the last meeting was the last meeting, because after that we got pandemic and we had no more only virtual meetings that we are having right now. But yes, was in 2018. It looked like a century ago, doesn't it? Since this pandemic arrived. But it was the last physical meeting between the members of the Brazilian Retina and Vitreoretinal Society.
Congratulations, and may I invite Dr. David Shaw to present his case. David Shaw is from Toronto, and University of Toronto and St. Mike's Hospital. And it's an honor to have you, Dr. Shaw, again, and it's very good to participate into your meetings, Zooming in on the retina. This is a great meeting as well. I guess it's going to restart soon. We are very proud of participating. Thank you very much for accepting the invitation.
Thanks, Hudson. Can you guys see the screen?
Yeah?
Good,
Yes.
perfect. So this is a 3.5-minute video. It's a surgical video. It's a surgical complication. And so I'll start the video and then we'll kind of talk our way through this a little bit. So it's a patient wherein I was on call, my fellow called, and as a 60-year-old woman presenting with a 3-day history of an increasing inferior visual field defect. And she has a bullous macula off detachment from 9:30 to 2:30 with a primary break at 11 and 2 smaller breaks at 12. So I went ahead and did a pneumatic retinopexy, very common at our hospital. Topical and subconj anesthesia, did a 0.3 cc AC tap, and then put in 0.6 cc's of 100% SF6 with a 30 gauge needle on a 3 cc syringe. Put it 4 millimeters posterior to the limbus at 11 o'clock with the patient in supine position. finished
Sure.
the injection, sat the patient up to look for the pressure, and he couldn't see the
David.
bubble, and then called me all panicked.
If you want to enlarge
And-
your
and-
screen,
And I think most of you,
if
you guys can see the video?
yeah, if you could enlarge your screen,
Yeah.
it's going to show
And so I
up.
think most of you guys can figure out probably already what's happened here. But you can see here, we took the patient to the OR the next day. So this is the Zeiss Artivo with the Calypso system, and essentially set up here with our three-port vitrectomy with the chandelier. And once you get the chandelier, it becomes very obvious that all that gas bubble went subretinal. So it's a total subretinal pneumatic, essentially. Put the gas bubble into the subretinal space. And you can see how much that retina was really pushed up by the gas bubble, really pretty much to the back of the lens. So you could see how careful I was when I was putting in the trocar cannulas to avoid the detachment. And once I kind of cleared out the vitreous a little, I was kind of hoping I could get to the bubble through the primary break, but it was very tricky. So instead, I just put in this 25 gauge cannula. You can see very nicely there that most of the bubble went away. Now, there were still some bubbles left behind. And so you can see with a bimanual technique, I gently kind of rolled or displaced the bubble to the primary break. And then in the subretinal space with the cutter was gently aspirating out the rest of the bubble. At this point, you can see we try to complete the vitrectomy, but the retina, because of the subretinal gas injection, the pars plana was detached, it was very mobile. So we put in perfluorine to stabilize the retina up to the back of the primary break, then completed 360 with a vitreous-based dissection and trimmed the skirt. And then we went to air. Here you can see I'm using a sandwich technique. I don't use this all the time, but in this particular scenario, I think it's a great choice because of the pars plana detachment. And then squeegee out the fluid through the primary break between the perfluorine and the gas bubble. And another trick I teach the fellows there is I never depress on the primary break, otherwise you close it. So I kind of depress next to the primary break to let the break gape so that I can get at the residual subretinal fluid. And once we're flat there, remove the perfluorine. And then here you can see 1, 2, and then the large primary break. So 3 breaks there in the retina, which is kind of what was seen on the pre-op evaluation. And then this was the 2 needle exchange for air to 20% SF6. And then the patient has done well since. So, so essentially, a very nice case of a very large subretinal gas injection from a pneumatic that was put in the wrong spot. And so, when we had a long talk about this, and we kind of went through pneumatic technique. And, some staff at our institution teach people to do pneumatic and just put the needle in wherever you want, and you don't need to worry about the position of where you put the pneumatic injection in. And you can see that in this particular case, obviously that did not work. He did his injection here at 11 o'clock. The primary break was at 11 o'clock. So, there's one of 3 ways that this could have happened. One was he went in the same clock hour as the primary break, and when he went in with the needle, went right into the break and then immediately injected immediately into the subretinal space, the whole bubble. The second is he could have put the needle in. All our fellows like to pull it back a little to prevent fish eggs. And he did do that. And when he pulled it back, he could see how that vitreous was quite taut and tight. And he may have been very well dragged the vitreous. That might have created some traction on the edge of the break as well. And then when he injected, the same scenario could have happened. It would have opened up that break, and then the bubble could have gone straight through there. The third way it could have happened is if one of those 2 smaller breaks that you saw when we did the laser was in fact created by the needle pass. So he went right through the retina with his needle in a bullously detached retina up at 11 o'clock. So I guess if there's any fellows on the call, I'm not an advocate for believing you can put your needle in a bullously detached retina in the same meridian as the break, and certainly not in the most bullous part of the detachment. So, the little trick there you could do, like presuming that you do most of your pneumatics on superior detachments, if you lift the patient's chin up and then put your injection of the pneumatic gas bubble in at 6 o'clock, I don't think you're ever going to get this happen to you. So I think that's kind of the teaching, at least on avoiding that picture you saw. And then in terms of management, hopefully most of us won't see that very often in our careers. You know, when you look back at what I just showed you in that video, I guess it's one of the pearls there is, you know, some of you might look at it and say, oh, I would just drain the gas immediately. And that was something we thought about, was should we just put the cannula in as the primary move and get the gas bubble out of the way to create space to more safely put in the cannulas. But the initial goal when we started the procedure was I was kind of hoping I wouldn't even need to do that, was that I would be able to kind of use the primary brake to get most of the bubble out there. But you could see that that really wasn't lending itself to be safely done because of the way that the brake was closed with the detachment so elevated. So I think that the cannula was a nice trick to help us once we'd cleared out some vitreous there, and then you could see how easily everything settled back. And I guess the other point is, because of the subretinal gas bubble, that is an emergency procedure. So if this happens, this is not something I would advocate waiting a week to deal with or 3-5 days to deal with. You need to deal with it straight away, because that retina is going to be, that bubble is going to expand. That retina is going to be pushed up against the lens. It's going to get sticky. You're going to get very rapid PVR. It's going to be even a bigger mess than it was. That was a pretty tricky case to do in the first place. So I think you got to go in right away. And I guess just the final point is that I already said it in the video, but it's an important thing I train all my fellows, is that, you know, often when you see people draining fluid in a retinal detachment, they drain through the brake, but they depress on the brake. And when you depress on the brake, you're basically closing the brake on. If you depress next to the brake, you allow the flap to sit and gape on the edge, and then you create a space for your cutter or your soft tip or whatever you like to use to drain fluid, to give yourself more room to kind of drain subretinal fluid. So I see it all the time in videos all over the world, people depressing on the brake as they're trying to drain fluid. And I think you should depress next to the brake on the edge of it to cause the edges to gape. So I think that's enough for me. Any comments or thoughts?
Yeah, great case, David.
Yes.
And yeah.
Congratulations again. Because it happened a couple of times, not to my fellows, but to me, which is another story. And it happened during a retinal detachment when I was trying to be quick and fast. And I had big tears, and then I saw the bubble going underneath the retina. So the things that I'm doing in there, when you have a pneumatic retinopexy, is do your fellows use indirect ophthalmoscope when they put the needle inside the eye, or they do it through the microscope blindly?
I don't even think they do it through the microscope. They just do it blindly with the patient lying back, and then inject like you would do an intravitreal injection of an anti-VEGF. So
that's the point. It's like an anti-VEGF injection. You inject it blindly, and people know that if they inject slowly, you get physics. So they do it rapidly, and of course they lose the sight of what they're doing. When you use the indirect ophthalmoscope, when you put the needle inside, you can see how much you're in. You can see exactly where you are. You can put it back, and then you inject, and you see the result immediately. And you can see if you make 1 bubble, 2 bubbles, 3 bubbles, or whatever. The next option that I had when I put some gas inside is the steamroller technique. That means that I'm injecting some gas, air. I'm changing my infusion to air. And I'm having the fluid needle with a 2-hand bimanual technique, the fluid needle near the tear, the way you beautifully described, sideways in order to open up the tear. And while I'm injecting air in front of the bubble of the retinal detachment due to the air, then this air that goes against the retina is pushing the air through the tear instead of perfluorocarbon, I'm using plain air for that. And a couple of times it worked. So now I see a lot of people that they do drain some big retinal detachment and bullet detachment with trocars, or they go behind the retina because they feel safe this way. So it's a new way of doing things. And I love your video. And I love to show us that even the minimum pneumatic retinopexy can have such an implication for the patient. But that's the only point I wanted to stress, is that I would prefer to use the indirect ophthalmoscope to do that instead of blindly doing it.
Yeah, I agree with Nick. Use the indirect against the red reflex, you can actually see the insertions of the needle. And I think a lot of the risk and complications could have been avoided by doing that. But I also know that there has been cut by the fellows and the residents over time in Toronto, that they just skip that and not bother with the direct view. It is cumbersome because that means that you have to put on the scope and actually see where you insert. But I think you're right, by not sticking into the same quadrants as the bolus detachment, you can also limit that. And the technique that I often do is that I insert it until I see the needle, then I just pull it back, just the position that it just disappear from the view. And that's probably as close you can get in terms of getting closer to the eye wall to minimize the fisheye formations. But I think the fact that you handle the case beautifully, I mean, as always, the technique that you show were very well done. The other thing that I found that sometimes, because coincidentally I have a similar case just a couple of weeks ago. The case was, there was fisheye, and then the fisheye bubble entered into the retinal bricks, and because there's persistent tractions on the bricks. And what I found, once you get in, sometimes what happened is that we're using the trocar system with the valve, the cannula with the valve. So when you put in, and so the bubble might not necessarily come out. So what I did was just put in the vent through one of the valve, and part of the reason why the case has a lot of fisheye is because of the vitreous was quite synergetic. So by just doing that part, that created some flow, and the gas bubble escaped through the brick because they were trying to get out anyway, as much as following the flow of the fluid. So I was able to get out 90% of the gas bubble, and then the remainder 10% I could just using a Q-tip to steamroll it through towards the brick, and then finish off the vitrectomy, and I was able to get rid of the gas bubble. But I totally agree with you that this case has to be done urgently, so they shouldn't be left because they will, not only the gas will expand, they will keep the detachment persistent. The retina will never settle down until the gas bubble is getting, you get rid of the gas bubble from the subretinal space.
So when Athanasios was making his comments, I had forgotten, I had a video many years ago I did for Kuris Brazai in his retina session in Tokyo. And it was a case that one of my fellows gave to me again that was essentially a PVR detachment, and had gotten PVR anteriorly, and they did the corvette, they peeled some membranes posteriorly, and then they went to air, and they got a big subretinal air bubble, like Athanasios was mentioning. All right, then they went back to fluid, then they did a little more peeling, then they went back to air again, and the second time they went back to air, When you see the air fluid exchange on the video, it's incredibly dramatic. The retina tear around where the PVR is, the edges are stiff. The whole retina rips radially from anterior to the equator all the way back through the fovea with a massive break. And so I show the fellows this video every once in a while to remind them how important it is to make sure you've adequately released the traction on the brakes and before you go to air, because that video will reinforce in your head forever. If you don't, what can happen?
I always tell them that how things are passing through the retina, if it's perfluorocarbon, if it's gas, if it's silicone oil, whatever. And I say when the surface tension of the hole is more than the surface tension of the bubble you put in, it's going to go through. So the surface tension, it has to be relaxed. Otherwise, don't inject anything. Even silicone oil can get back. If the surface tension, if you leave a stiff retina with a hole, then it's going to be. So it's the surface tension against the surface tension. And they completely understand that. And I tell them that that's the point of a retinotomy. If you cannot go any further, you should do yourself the retinotomy and not let the bubble do the retinotomy. So bubble-made retinotomy, it's to show how much the force actually that's exerted. And you always have cases like that that make people crazy. You don't see them every time. But I got a case for you later that you'll never see that before. So I'm keeping a little bit for later.
All right. And Sasamoto, do you want to comment on Dr. Shao's case?
A beautiful case. Just I want to mention to ask to all the panel and colleagues how often they practice the pneumatic retinopexy in your centers. Here, probably it's like 20% of our cases with a superior break, but I want to know the opinion of our colleagues, please.
In my practice, I think now it's about only 5% of the cases, and earlier it was maybe 20%. I have a point for David, I think wonderful. One is to, as a mentor, and when a fellow makes, I think you should give them courage and confidence. And at the same time, as a mentor, we have to manage. And I think, David, you've done a fantastic management of the case. And I think this is my lesson to every fellow when I tell them, please read the complications first, then start doing any procedure right now, like putting in the trocar or even giving if you're giving a regional anesthesia, if you're going to do a retrobulbar, keep anticipating the axial length. And similarly, when you're intravitreal, I think you have to all the time know with the whatever tactile sensation, whether you use, I actually use an indirect before I sit on the microscope, just to see how the patient is behaving, or the retina is behaving on the table, and then use the needle, inject the gas. And I think the fellow, as you said, has gone directly into the microscope and probably thought they're injecting into the vitreous and it's gone subretinal. So I think one is to all the time anticipate what problems can happen. And I have already, every time a retina case, as many cases, we have a drawing check. That means the evening before, we go through all the case sheet, including the detailed drawing. And I insist on detailed drawing by the fellow, and then make sure they draw the vessels and the retinal break. So that the idea is to understand the topography and the retina well, so that they will anticipate and avoid the complications. Sometimes, in spite of all the precaution, it can happen. And if it happens, we have to follow what you say, David. Great case.
Thank you for your comments. And we are always learning with those cases. And I had a couple of cases similar to this one. And the breaks were so peripheral. But I love the comment from David Chow that we should not depress or make indentation at the site of the break. Otherwise, we could well close it, and so making things difficult and or more difficult. But oftentimes when the gas is subretinal and it escapes through the sclerotomy, that's a relief for us, and that helps a lot. Thank you very much, Dr. Shaw. Great case again. And now we are having Dr. Marcelo Murilo Sasamoto, to introduce his case. Welcome, Marcelo, from Bolivia, our great friend.
Thank you, Hudson. Okay. Can you see the screen?
Yeah, it's perfect. You could, if you want to enlarge it to make it more
Sure.
wider view.
Okay, it's a female, 61 years old, blunt trauma in the right eye with a traumatic cataract, probably a posterior capsular rupture from the blunt trauma, retinal detachment, 3 retinal breaks, and a traumatic macular hole. The procedure was, we performed phacoemulsification, vitrectomy. We clean and extend the retinal breaks to have more of a symmetrical shape. ILM peeling with the inverted ILM flap technique for large macular holes. Fluid air exchange, endolaser, silicone oil at the end, and we use methotrexate, 1,200 micrograms. So this is the traumatic cataract. You can see the 3 with the macular hole, the 4 breaks for the blunt trauma. The endodiatherm to recognize the breaks. Then we do it after that using the brilliant blue to perform the ILM peeling. It was a really tricky and kind of complicated peeling because of the retinal detachment. But we're doing right now this technique with an ILM. Then put the 3-piece IOL and continue with fluid air exchange. Finishing with laser, silicone oil. And at the end of the procedure, I put methotrexate in this case. You can see the post-op OCT where the ingrowth ILM is present, and it's 1 month post-surgery, and we're waiting any more changes in the macular hole. I, like Dr. Chang, I love wines a lot, so I love your cava also. Thank you.
Good, very good, yeah. And Nageswar, you want to comment on Marcelo's case? Nageswar Rao is from India, and before he reaches the microphone, he's probably around. Dr. Athanasios, could you comment on Marcelo's case?
Well, it's complicated and difficult because you get the macula, you get the periphery, and he did a beautiful job. And the end result showing that he controlled the case because the surgery is controlling the case.
Yeah, nice laser. I like the laser. It's beautiful around the breaks there. Beautiful imaging as well. Do you record your videos with wide angle, and which machine you use, Marcelo?
It's in the Hug Stride microscope. The name is MIOS, M-I-O-S 5, and that way I record all my videos.
Yeah, very good.
What kind of system you got? You got Biome, ABUS? What kind of system that you're using? Wide angle.
Usually use the Biome 2. ABUS 2.
ABUS 2, the last one. Yes, that's what I do also. This is my favorite. Yeah.
Yes. Me too.
So the issue of a traumatic macular hole detachment, if there are no other peripheral breaks, unlike this case obviously had the big peripheral breaks there. The literature in the last couple of years is now evolving to decide what's the best way to get rid of the detachment, which is one issue, and the second issue is to close the hole. And when you look at the evolving kind of work done around the world, it seems to be that although originally we talked about stuffing the hole, inverted ILM, and just folding all the tissue in there, that certainly would close the hole and the detachment would go away. But the closure of the hole and the visual outcomes now appear to be less effective or less impressive than when you do an ILM flap. Just a piece of ILM covering the hole rather than stuffing all this tissue into the hole. And so I think we're at a stage in macular hole surgery where things have gotten exciting and more interesting in the last 5 years. But in that context, though, we need to figure out which of these techniques we all see at meetings makes the most sense and in which scenarios. So I think in a macular hole detachment, if we want to do an ILM flap, one of the bigger issues I hear from our own fellows typically is where do you drain the fluid? Do you drain it through the hole? How do you get the flap to stay where you want it to? Now, in your case here, that would have been a lot easier because I had all the peripheral breaks to drain the fluid out. So you could have created that flap and then using PFO, or you could do it under the PFO and squish out all the fluid peripherally and keep your ILM flap in place. But in a lot of macular hole detachments, you don't have the luxury of a peripheral break, and then you have to decide, you're going to create a little peripheral break to drain out the fluid, or are you going to drain through the hole? And those are kind of some of the variables I'd say in the context of a macular hole detachment that we're still struggling to figure out what the best way to do is. But I think for me nowadays, if it's a macular hole detachment, I try and create an ILM flap. I'll often drain through the hole if there's with a small kind of like 39 gauge, like the subretinal cannula, and just gently drain the fluid out there until I can get the thing dry, and then I'll put the flap across it once I've drained it, but and then leave it like that.
Yes, actually, that's a big issue, the fluid. So sometimes I perform a small hole to extract that fluid. It's not a good. I mean, it's one of 3 or 4 options that we have.
So David, if you drain through the hole with the flap already created, it will be technically difficult because that flap will keep coming towards your drain. And will you consider flatten the hole and then do the ILM flap after that? Meaning that you can drain the detachment down, that you can put in fluid
drainage,
or air fluid exchanged,
okay.
Then to put in PFO.
Yeah,
and you can put the fluid back
PFO.
in. Yeah, and because it's very difficult because you have a mobile flap, and you try to drain the fluid, and so.
Yeah, no, there's no question about that. And I have another video showing exactly what you're just saying. I created the flap, drained through the hole, and you can see the flap keeps wanting to come, and it makes you very nervous. So you're absolutely right. So perfluorocarbon in that scenario, and then peel under perfluoron is your other option for sure.
Yeah, I love to peel under perfluorocarbon liquids. I thought it could be difficult in the beginning, but as soon as you get the membrane, the ILM, if you just let it go, you just grab it again. It keeps stable, and it avoids the flap in case the flap is a free flap from going elsewhere. So I like the idea, and I'm pretty comfortable of peeling under perfluorocarbon liquid. If you have a good staining with brilliant blues, that's what I use. And Nagaswar, are you around?
No.
You want to comment?
Hi. Hello.
Yeah, we can hear you. Yeah.
Yes, actually, my question actually, I wanted to ask whether Dr. Marcelo has performed under PFCL, but this has already been discussed. Nothing to ask, but he has done a good job. But that's what my comment is actually. If you do under PFCL, the flap, the ALM peeling may be more controlled than doing without PFCL in a detached retina.
All right. And we have the honor now to call Dr. Professor S. Natarajan to comment, to give his speech on his next case. And also Natarajan is with us since the beginning of Retinawesome. It's an honor to announce again and again here that we are in the first year of Retinawesome, and we are together all over this pandemic time, and we are happy that we are together. And this is the new way, I think, for presenting our cases and meetings. And fortunately, things are going to get much better because we are getting the vaccines. So we hope Brazil, US, Canada, in all countries, India, they're going to get just great. So Natarajan, welcome.
Thank you, Hudson. I think before the Retinawesome, we both did a first webinar on March 28th. I think it was a late night for me and morning. So great to be with you, Hudson. And then our friendship starts from the Retina World Congress and ASRS. So I'll share my screen.
Sure, I think you are allowed to share that.
Yes.
And if you want to enlarge it to have a better view.
Yes.
These birds are around your garden?
Yes, it's like parrots, and I love parrots, and if they are there, just like around my. We are surrounded by a lot of green trees in Mumbai. Otherwise, Mumbai is a concrete jungle like Sao Paulo, but this part of Mumbai is full of trees. So I call this a verdant font of youth. So I'm coming back to the case.
Application of self-retaining twin light endo-illumination in diabetic retinal detachment, a new approach. Stilettos, unique insertion instrument streamline, introduction of twin light shadow.
So this is a video which will show a twin light endo-illumination, which is actually designed by, this is a stiletto for introducing the twin light, so that exact 3.5 millimeter we can introduce this, which I actually made by, I think, Dork, and then designed by our friend Klaus Eckhardt in Frankfurt. And here the idea is that instead of having a two, this was before the trocar cannula system when he introduced this. And the idea is to have a good illumination so that you can avoid shadows. And that's how this, I put it in the 6 o'clock meridian, and there's a 20 gauge infusion line. And here you see after completing the vitreous and the vitrectomy and also releasing the tangential traction, I'm holding the membrane in one hand, and it's a real true bimanual vitreous surgery. Otherwise, most of the time, I remember Giovanna explaining that it's like holding one hand with a torch and then only one hand you're working. And here it's like a bimanual, and now with the advanced the proportional mode and other things we can put once, I think, where you can probably, you don't need this, but I think you can see in this sort of patient dissection, there's a possibility to remove the membrane en masse, and it can help in studying some, you can also segment, you can delaminate, and you can proceed. You can see some ooze happening in spine, then you can use intermittently the cutter, and which we can nowadays do with the proportional mode of the cutter, but it may take some time. And I think definitely the time should not be the constraint. The quality of surgery and the avoiding iatrogenic break should be the aim, and also to release all traction so that you don't have a recurrent fibrovascular proliferation as well as any iatrogenic break. You can see, you can pull the membrane. So this is where I keep telling the fellows that you should learn this tactile sensor, even though you don't touch the tissue on your own, but I think you have to, through the way you're holding and the way the retina is behaving, you should be able to visually understand and make a tactile response to your brain through your hands, so that you can avoid retinal breaks happening. And I always say that, and this is how we can clean up the whole retina, and so I think the whole idea is maybe the surgery took for 2 hours. It's an edited video, and I have similar cases there. And I keep mixing up the techniques. I'm not fixed with the fixed idea that I should do only this. So I have a game plan, like how Steve Charles has written in the last surgical self-education. It's like playing a soccer. You and your team, that means your armamentarium and your mental game, and then how the retina behaves on the table. So you do any game plan the night before, but on the table, you have to change the game plan. And this patient, it went well because I wanted to put the stiletto and use it. And nowadays I can use one chandelier and use this. Since I thought I had this video, which I love this video to show as a good teaching video, I selected this. Thank you, Hudson. And I'm open for
great case.
comments.
I love to do diabetic retinopathy patients, and I usually, I do not use very much scissors, but I like to use the endocautery a lot. And I like pretty much like Maria Berrocal does, and I follow pretty much with similar techniques. And I like to remove these membranes with the cutter as well, with the forces that apply to the specific system you're using. We're usually using the Constellation or Stellaris, and that goes well, but they are pretty difficult because there is the tractional component as well involved. And Dr. Jorge Mitri would like to comment on the case.
Yes, I enjoy very much the surgery of Dr. Natalia, but I think I saw this double light source some years ago, but I think they illuminated just the inferior part of the eye. Is not so good for the upside. For this reason, I use the 108 degree each fiber optic. Other thing is that about the surgery, I think the diabetic retinopathy, very, very advanced case like that, I think that the retina is very atrophic. So you have to use silicone oil at the end of surgery, about 100 of the case. So I think the best way is just remove the traction over the macula and leave all the other parts not attached. So you can let the macula touch it and don't use the silicone oil. I think this is the best result you can do. You can have. You don't manipulate so much the eye. This is what I would like to say. Very nice, Dr. Nageswar. Very good.
Yeah, Natarajan.
Thank you, George.
And Natarajan, I will ask Dr. David Shaw to comment on your case as well.
So the twin light chandelier was so some of you remember way back I did a lot of work on endoillumination, and the origin of the twin light chandelier was from Klaus Eckardt with Dork. And the reason he created it was that he was upset with a single fiber chandelier that he was getting shadowing. And so the origin when Dork put that together was the shadowing. Now, the original kind of twin light chandelier with Klaus was very fidgety to put in. All right, it was tricky at the best of times to put in those fibers, and iterations of that concept in the last 10 years have gotten better at that. All right, but at the present point, yeah, I think the concept of putting a twin light and putting them 90 degrees apart, you're right. It probably makes a whole lot more sense if you're going to do twin light to put them 180 apart to avoid that particular issue. Personally, I mean, I've used chandeliers for my whole career now and lectured on it forever. And I've always trained my fellows that I don't really need the twin light. But I think what happens, and I've gotten these complaints when I've given talks around the world on chandeliers, that, oh, I never get a video like what you show on the meeting. My view isn't as good as what you show. The chandelier isn't doing that, right? And so what I kind of tell my fellows when I'm training them is, yeah, there's a lot of the time when you insert the chandelier, you have to pay a lot of attention to how you angle it, how you tape it to the drape, so that if you get the fiber to be aiming ideally in a 360 global manner. Now, if it turns out it isn't, it's not the end of the world. So this is why I'm always telling my own fellows, don't worry about it. Just tape the chandelier down so you can work on one side of the eye and do 180 degrees, and then just tilt the fiber the other direction, and then you can do the other 180 degrees. And interestingly, Klaus has just come out with the product a year ago with Vitrec, which is a little plastic device that sticks to the drape on the forehead. And it's a malleable directional mover of the chandelier fiber. So it's a single fiber chandelier, but it's essentially now allowing you to tilt the fiber from one side to the other side to achieve what I just said that I do by moving the fiber and taping it to drapes in a different direction. So that's my own take on the single fiber versus the dual fiber chandelier. My other kind of comment would be that the biggest change in instrumentation that has made diabetic dissections easier in the last 5 years to me is the beveled tip probe. And so those of you that haven't had a chance to use a beveled tip probe, and that's an Alcon product, and I think they're the only, well, they will be the only ones who have that for a while. That to me is more impressive than going quicker and quicker and quicker. So I know when I went up to the 10K and then the Hypervit, which is essentially 20K, the speed issue wasn't as impressive to me as the beveled tip, allowing me to use the cutter like a spatula, like a shovel. And so we actually published a little technique variation that we call shovel and cut, which is really using a beveled probe to slide the tip under the edge of the membrane. And because the port is now closer to the tip, you can now feed the tissue into the port, and you just kind of push it along like a shovel, and the tissue all just feeds right into the port, and you can remove diabetic plaques and membranes in that manner. And it's something I would never have done with an older cutter because I wouldn't have had the confidence in its ability or safety to do so. So yeah, I guess that's my other point is bevel tip probes. If you get a chance, try it. I think it allows you to do complicated diabetic dissections a lot easier.
Can I talk to the master? Because to me, illumination systems and color and everything else that we do, we owe it to Carlo, and he's a master on that, and I learned a lot of him. Can I use something that you said before in older days, like in Tokyo? In the old days, the chandelier light, 25 gauge that I used for the first time in 2004, had 5 ansi-lumen brightness. Then the new chandelier lights can go up to 30. So there's a total complete different of kind of illumination that you got from the same trocar, from the same Alcon system, 5 to 30. So you got a much better. The next thing is, he showed me that the assistant for these cases, when you have a wide angle observation system, is not to hold the lens anymore, is to hold the illumination. Because this way I learned how to put a steady drape at the edge of the holding of the cord of the pipe, just a small steady drape, that extends like a handle, and then your assistant, if he can look through the binoculars, he can show you exactly where you're working by mobile. So his job is to show you which way you need the light to go towards. So there are two ways of doing that. And the next observation I would like to make, I hate the microscope that has a co-surgeon system. That means that the assistant can adjust the zooming or can adjust the focusing, but he doesn't see exactly what you want to see. So in order to be helped completely right by the assistants and the illumination, he needs to have a system, observation system, to see exactly what you're looking at. And then he can follow you and help you. So the system becomes important when he helps you with the illumination. And I learned all these from David Cho. Sorry for that. I'm just telling old things to new people because I know that everybody doesn't participate in these cases. And thank you, David, again for all the tips you gave me. So many years.
To finish this case, thanks for the comments.
Can I ask you
Emmanuel?
a question for everybody? How is the result when you use silicone oil and remove all the membranes? I don't have good result because the retina is very ischemic. And I prefer to just save the macula in this case, or remove some traction and leave the membranes, because the eye is stabilized in this way. So when you use silicone oil, you can put the retina in the place, but you don't have good result. What do people think about?
You have to use silicone oil whenever you should use silicone oil, because silicone oil is just something that you put in the eye every time or whenever you like to. If you don't put it in the right way and in the right patient, in the right eyes, then you got the trouble of the silicone oil without the benefit. So it's a whole book. Zivoinovich, with my friend Nataraja, who is in the same age like I am, but he looks like my son. I always have to say that. And we went to Relio Zivoinovich, and he made a book that is the holy book of silicone oil. A whole book of how to use the silicone oil. And that was in 1990, something like that. And it still stands for that. So if you can look through the internet to see the use of silicone oil by Relio Zivoinovich, it's going to be great. But I agree with you. If you use it without a purpose, without an option why you're using it, then you produce damage to the eye and not benefit. And I'm with you this way.
I think I agree with Thanasis, George. Dr. Jovanovic has written a chapter called Use and Abuse of Silicone Oil, which he used to talk all the time. And people used oil in those days, just if the retina doesn't get settled, they inject. And he used to say, that's not the way to use oil. And I think you have to remove all membranes, make sure you don't have any traction. And then if there's a iatrogenic break created, make sure there's no traction around the break, and then use the oil. And oil will not do magic. You always used to say, and oil is only a tamponade, and oil is not an instrument to settle the retina.
But in diabetics, just one quick comment. In diabetics with one eye, you can put gas in one eye, and you have the patient having all the complication of the gas. That means late viewing, rebleeding, and all that thing. In one eye patients that you remove everything, even if you don't use it, silicone oil can give them vision immediately and can protect you from rebleeding and protect you from small mishaps that will happen, and you can do some more laser and you can have a clear view. So the patient is very happy to see when he has only one eye. So one eye patients, even if I can use gas, I'm using silicone oil, because this way I prevent the troubles that the gas is producing, like rebleeding or viewing impairment for a month or something like that. Sorry for being passive on that subject. But
excuse me. No, it's a very good discussion. Do you remove this silicone oil? in this very great advanced diabetic case, or do you live forever?
I have cases that I leave. I have trauma cases and diabetics. I have cases that they stay there for 6, 7, 8 years, silicone oil. And when I change it, because we have emulsification, I do silicone oil exchange. I remove the silicone oil and I put fresh silicone oil again, because there are some eyes that they wouldn't work without it. And these cases, the big help I had was from 5,700 Sandy-Stokes silicone oil by Goiter. This silicone oil, I don't know, I'm not a chemist, I'm just a shoemaker, that when I started using 5, 6 years ago this silicone oil, it stays there for much longer. I'm not in the case in diabetic that I have to remove the silicone oil in 6 months. And usually when they are phakic patients that I respect the lens, because I like the lens to be there, not to remove it in the first place, I do the removal of the lens and the silicone oil in the same time. And if something goes wrong, I repeat the silicone oil injection. So it's a tool for difficult eyes, difficult cases, but it lets the patient to see immediately after you finish your operation. And rebleeding is very important for the vitrectomy in diabetics, which causes that.
Yeah, so I agree with Thanasis, but the only thing is, George, I think that every patient, you cannot decide whether to leave it permanently or leave it for years. And I think, according to me, we decide patient to patient. Some eyes I leave for fewer, but only thing I keep telling the patient, particularly most of them are one-eyed because they've already lost the other eye. So I tell them, have a watch wherever you are, because you're far away, you come far away. Watch the optic nerve, the cornea, the intraocular pressure. And I think any of this happens, we have to remove the oil. And then sometimes when you remove the oil, you have problems. So that's where the first surgery, which Jovanovich always mentions, the surgery is very important. That means you remove all the membranes as much as possible, and then re-inject the oil. If you don't do that, the fibrous proliferation can go around the silicone oil, it can proliferate, then it can have a problem when you remove it. So sometimes it can become an inoperable case, even though you had attached macula. So you have to be extremely careful. So if the first surgery is done well, or a second surgery we are doing is done well with no membrane, and I think you can leave the oil as long as you want. But there have been histopathological reports that oil can produce this pallor, and that can also reduce your visual acuity. So the whole idea is you want the patient to see the best. So I think you have to have a balance. Some eyes you may have to remove early, some eyes you may remove at the end of year, some you can permanently leave it, provided you are patiently observing the patient. As he said, some cases will need change of oil frequently. Sometimes some of the patients think that we are like an automobile industry, keep changing the oil.
Very good.
Thank you, Natarajan. And I would like to invite now Dr. Lam, Professor Lam, my professor from the University of Toronto, and now in Hong Kong. Could you approach and give your speech for the Retinawesome 9?
Sure, thanks, Hudson. I just want to share the view. Well, thanks again for inviting me for this Retinawesome 9, and congratulations for maintaining this ongoing platform for the discussions. So I'm going to share with you a somewhat simple case, but just have some interesting aspect, and you will see that in the video. So it's a 67-year-old woman with history of neovascular AMD, and it's been treated for the choroidal neovascular membrane with the anti-VEGF. And then she suddenly presented with a decrease of vision in the affected eye. And he was diagnosed with a breakthrough vitreous hemorrhage with subretinal, from the subretinal hemorrhages. And we kind of all know about the incidence of breakthrough vitreous hemorrhage from the age-related macular degenerations. It's far more common to see in PCV. The incidence of breakthrough vitreous hemorrhage is For AMD, it's about 2 to 7%, while it is certainly a lot more for the PCV patients. And PCV patients tend to have more bleeding, a larger amount of bleeding compared to the AMD patients. I wanted to show you this schematic because it showed the different etiology for vitreous hemorrhage, and one of that is the breakthrough vitreous hemorrhage. And in here, you actually show a break in the retina surface for the blood to get into the vitreous cavity. But interestingly, I'm sure many of you have done the cases where there's vitreous hemorrhage from a hemorrhagic AMD patients or PCV patients. You don't always see a retinal break. You clear the hemorrhages in the vitreous cavity. You see some subretinal hemorrhages, but you don't always see a break. When there's very large subretinal hemorrhages, you can either deal with them with the subretinal TPA, or in cases when there's very, very large hemorrhages, you do retinotomy. So for these patients, I went ahead to do the vitrectomy. So after clearing the vitreous hemorrhage, I saw this little things sticking up in the retina in the area where there's retinal hemorrhages. I was wondering, what is this? So I used the cutting probe to push on it. It's quite friable, and it's quite easily removed with the cutter. So I'm sure some of you already have some idea what it is. And it is actually a subretinal clot that has pushed through a brick in the retina and presenting in the vitreous cavity. So I look around, there's certainly a very large inferior subretinal hemorrhage. You can see the disciform scar, you can see this there. So I want to look around with this indenter to check to see if there's anything else. You can see the scroll indent. And then I went back there. Again, you can see that little thing that I removed, that little clot that I removed, came back. In fact, when I press on it with the scroll indenter, it came out like a toothpaste. And more and more of these subretinal hemorrhages came out from the subretinal space into the vitreous cavity. Almost looked like a little worm that is in the vitreous cavity. Although this is not a worm, it's just the clot that came through. So I thought maybe this is a good way to get rid of the rest of that subretinal hemorrhages in that area. So I cleared that up with the vitreous cutter, and you can see that the clot come off very easily with the cutter. And then I indent that area again to try to get rid of more of those clots. And when I indented, a little bit more came through afterwards. So in this case, there's actually a break in the retina where the clot is, and that's how the breakthrough vitreous hemorrhage happened. And you can see I just indent that, and there's a little bit more clot comes through. There's a different way of getting rid of subretinal hemorrhages, not the injection of TPA, not the retinotomy. And you can see the clot is there. So, so I repeat that maneuver a few more times to get rid of the subretinal clot that is in that area. And next you see, then I do an air-free exchange after that area seems to express no further blood. And then I laser the retinal break that was there where the breakthrough hemorrhages occur, and I think that's, let's move forward a bit more quicker. And so there's a retinal defect there. So I thought this is interesting case to share with the group. And first of all, I guess to find out how often you actually see a retinal break in the case when there is a breakthrough vitreous hemorrhage from a subretinal hemorrhages, either in case of AMD or PCV. And I just show you an interesting way of getting rid of subretinal hemorrhages. So, comments?
Great case, and I guess it's not very common, but probably the break could be there sitting there for a while. We don't know, but
yeah, but most of the time when we do cases like this, I don't see a break. I clear the vitreous hemorrhage, you see subretinal clot, and that's it. So the way I understand it, the blood probably just kind of diffuse through the retinal layer, and that's not truly a retinal break. And despite that schematic drawing showing how a breakthrough hemorrhages occur. But this is the first time, honestly, it's the first time after that many years that I truly see a break in the location of the clot where the blood comes through. So.
Yeah.
What are the temporarily used, Dr. Lam?
Oh, well, the just gas. I mean, it was a small round break and no tractions.
Post-operatively, did you observe continuous bleeding into the vitreous cavity?
No, the patient stopped bleeding already. So there was no further bleeding. And although the vision wasn't great, because you can see there was a large disciform scar, and the clot slowly kind of get absorbed and fibrotic. So there was no complication with this patient, no oil needed, and but the vision wasn't that great.
Because why I ask is because, in fact, I had a few cases. In fact, we discussed in the Retinawesome meeting also. One case in the initial days that PCV bleed, actually it keeps continuing. The bleed comes even though you use silicone oil. Most of the 1 or 2 cases I saw, the subretinal blood keeps coming into the vitreous cavity, and in one case actually under the silicone oil also it has came all these ghost it appeared like white blood in the AC and in the vitreous cavity, and in fact sub silicone oil it was there. So this type of complications actually 1 or 2 cases I saw, because in PCBs particularly the bleed continuously it comes. It's a continuous process of bleeding.
I guess there's more bleeding associated with PCV than you will see in AMD patients because of the polyps. They are kind of connected to the choroidal vasculature, and they are larger vessels, so the bleeding tendency are higher, and if they do bleed, they tend to get a bigger bleed.
Yes.
Dr. Lam, so I agree with you. I mean, I think that's historically what we've always said, right? The blood can get through the retina and cause these breakthrough vitreous hemorrhages. I personally have never seen a break like you just showed, but I wonder whether or not there's been some small little clots on the retina that I wasn't aggressive at picking at and pulling at, and whether or not if I had, there might have been some breaks I just didn't see and didn't cause a problem because they just scarred down and the break closed on its own. So interesting case to bring up that kind of issue. The other thing is we did a couple years ago when our fellows we did kind of a grand rounds on PCV. Was this patient treated with anti-VEGF alone or with combo with PDT for the PCV? This is how they present.
Yeah, this is actually not a PCV patient. This is an AMD patient, okay. And all right. So she was just treated with anti-VEGF. Yeah.
Yeah. So one of the things that I learned from the literature review with our fellows was that I hate doing PDT. It's not really easily available in Toronto. It's not reimbursed and covered. Patients have to pay for it. So I've been trying to justify in every way I can the reason to do anti-VEGF therapy alone for PCV. So I use EYLEA because of the trial data that suggested monotherapy with that can be as effective as combo therapy. But the one interesting caveat is that the literature does show that the rate of catastrophic hemorrhagic complications, horrible hemorrhages like what you just showed, is far, far greater on anti-VEGF therapy alone than it is on combination therapy. So PDT can really reduce your risk of these kind of massive hemorrhagic complications. Fortunately, they're very rare, but they're still significantly more common on primary anti-VEGF therapy than they are with the addition of PDT, which I didn't like because it's not what I wanted to hear, because I wanted to justify why I do anti-VEGF therapy, but it didn't change what I do. So I don't do PDT still because of how hard it is to do here in Toronto, but just a little teaching point.
Yeah, I just want to give you some support for your decisions. We see a lot of PCV in Hong Kong, and interestingly, I should be doing a lot of PDT. We have a PDT machine that Novartis get that move around in the city to break that problem, to solve that problem of not having adequate amount of machines for the center, because you don't use it very often, but so basically the machine gets rotated around from different center so that you can have access to it. But that's not my point. My point is that when I actually look at a lot of those cases with PCV, they often have branching vascular network in between polyps. So when you only treat the polyps with the PDT, they keep coming back with still recurrent problems of exudations and hemorrhages potentially. And some of the branching vascular network can be quite large. So even though we do have the PDT machine and we do them quite often, and in fact, on a weekly basis, we often have 2 or 3 cases that we may even, sorry, on a monthly basis, I meant, we had 2 or 3 cases that we booked. And but it doesn't always work that well, only in those cases with very discrete polyps. And so we still have to rely very much on the anti-VEGF to control the branching vascular network. The branching vascular network essentially are the choroidal neovascular membrane in between the polyps. So I think they are a combo problems in the PCV cases majority of the time. So I think what I meant to say is that using the anti-VEGF still predominantly the management that we approach to.
Len, in the case that you just showed, did you use the PDT and the anti-VEGF prior to the hemorrhage?
No, we were using the anti-VEGF, but not the PDT, because there's no view to the back of the eye with the vitreous hemorrhage. Prior to that, we're just using anti-VEGF only.
Okay. Dr. Lund, the problem of the PDT is that don't have in any part of the world, the Visudyne don't exist anymore. Nobody can buy it. Other thing, we
can try to ship you some from Hong Kong. we have access to them still.
Do you think you have it?
Yeah, we have it still. Like we have 4 cases booked for next week.
Oh, good.
Yeah.
Very good. I will try.
I bought a PDT machine in 2001 and introduced PDT in India, and I have one. But fortunately or whatever, I don't see much of IPCV. We see, but not like Hong Kong and Japan and Singapore and Malaysia, I think. But here in India, it's less.
Do you have in Hong Kong? I right, Dr. Lan?
Yes, I can find out from the Hong Kong reps to see whether they have a South American connections that may be able to help you with the supply.
Yeah, it would be nice.
Let me understand your case. You have like a cord leaving from the road. Is that, I understand?
What happened is that there is a small break, small hole in the retina overlying the blood clot. So when I scleral depress to examine the eye, it also pushes the clot into the vitreous cavity like a toothpaste. And I didn't realize that at the beginning. Then once I realized that, then I used that hole to get rid of the rest of the clot that was underneath the retina. Yeah.
Right. Very good case.
Really.
Congratulations.
Perhaps Seti,
Thank you.
you want to comment on the Lam's case?
One last question to Dr.
Yes.
Lam. Do you intend to do PDT or did you do laser on the polyps to avoid this hemorrhage to come back?
This patient doesn't have any more polyps. She mostly is AMD patients, not a PCV patients. So there's no need to worry about doing either the PDT or focal laser. If we do have a patient with PCV, if the polyps are extrafoveal, we are happy to treat it with just argon lasers.
Yeah.
When the polyps is near the macula, that's when we use PDT. This is expensive to use PDT.
All right.
How
Okay,
old was that hemorrhage, Wai Ching? Do you know?
The hemorrhage is, we waited about 2 months before we went in.
So I think that's the key feature, right? The timing. So I think if you'd done that a month early, it doesn't look like that. If you do it 2 months later, it probably doesn't look like that either. So
Yes.
I think that's kind of it was a very cool video to see the toothpaste coming out. And I've seen something like that before, but I would guess, and we don't understand this, that it's clearly an evolution in what happens with subretinal blood. And there's probably a time span where it looks like that and behaves like that. And if you operate at that particular time, you would get that kind of a drainage.
Right. Because it's still a little pinkish.
Vahab, here's your time now. You're around? Vahab, Seti. Do you want to discuss on Dr. Lam's case? And so we move to Dr. Athanasios Nikolopoulos' case. I'm sure it's going to be a great case. Athanasios, are you ready?
Yes, I think I'm ready. And first of all, I would like to thank you for inviting me to your company, which is a group of friends now, from what I see. Most of them from Toronto, which, if you don't know, I belong there too, because of Wai Chi Lam.
I know.
And
I saw your
it's an extraordinary site to be. It's a city with 7-8 cities included. So you just change the corner, go across the corner, and you find another city. But it's incredible, and I love it. So I'm trying to share my screen, and it has. Okay, let's say why it doesn't let me share my screen. I've got the video here. Okay. Do you see it?
No.
Not yet.
Not yet.
Not yet.
Home sharing is turned off. Okay. Zoom. Join a meeting. I have to start again because it doesn't let me to share. I don't know why.
Oh, just a moment. Let me. Maybe I think you were as co-host. Yeah, it's allowed. Yeah.
It's allowed.
Okay. Yeah, you're
But
allowed already. Yeah.
I don't have. Okay, if it's allowed, can you do it for me? No.
Sure, of course. I have here your video. So let me share it.
No. The thing is that I've got my video here in my screen, and suddenly it came up, join a meeting thing, and with signing and everything. It's like you see.
You might have opened up another Zoom. You may have opened up another Zoom. So you have to close the other one and just keep this one.
But it doesn't allow me to share.
Yeah.
Open system. allow Zoom to share your screen, open system preference.
Maybe you could close and open it again because it's allowed to share over here. So we allowed you to be there as a co-host. So everybody's allowed to share the videos. Maybe if you don't find
Sorry
it,
for the mess, but it's not my fault. I was ready, and
well, no problem. If you don't find it right now,
give me just a minute.
You could send
And
it to me.
Zoom will not be able to record. Okay, quit and reopen. It says leave meeting here. Okay. Now, let me try to share again. Okay, I think it's better. Can you see it now?
Oh, yeah,
Yes.
no, it's perfect.
Okay, I will enlarge it. Can you see the video now?
Mhm,
Yes.
Sure.
Yeah, okay. We got a case where, as you can see, I'm always using a chandelier. We got a drop nucleus, and I've been asked to remove it after a couple of days. So I using always when I try to remove, and then to my surprise, when I was getting in, I saw this. I saw an inferior retinal detachment, and no nucleus. Like I lost the nucleus. So I was looking behind the iris, I was looking if it's stuck someplace, I looking if it's breaking someplace, and then I saw this. While he's trying to recapture the nucleus, he made a big tear on the side of the bullous detachment. And still, I don't see the nucleus. And I'm trying to go inside. And then, suddenly, I saw that the nucleus was on the other side of the detachment, not at the side of the tear, but on the other side. Because of the fluid behind it, it went. So how can you remove that? So I use a flute needle with an energetic suction of 650, as you are going to see now, suction. A flute needle with a silicone tip, like this. And I tried to suck the fluid, and I was hoping that and there's the nucleus. Not a small one. And now I would need the help of the panel. How you can remove this nucleus from a retinal detachment with a big tear, an inferior retinal detachment from an 87-year-old man, which seems very hard to remove. Any ideas?
EFCL maybe.
Okay.
Perfluorocarbon liquid.
Sorry?
EFCL may be used to flatten the retina. Then we will remove the.
How to flatten the retina? How?
By injecting PFCL, we can do a.
You can use the. Excuse me. You can use the hilum, to close the roll, posterior roll. So after you can use you inject hilum or viscoat, and after that you put the perfluoro to put the retina.
Whenever we try with such a big tear and a floppy retina that is moving about, all the perfluorocarbon, all the hilum is going behind. So it's not a case of putting anything inside the eye because it would go behind the retina. This is what we had experienced before, and we wouldn't like to repeat that, especially peripheral. Look how big the tear was from here to here, and it's open mouth. Imagine that it got this lens inside by itself. It was sucking the whole lens. So imagine how much peripheral carbon it would suck this huge hole. So the thing that I'm doing, and this is a take-home message that I'm using for my fellows, is that we never touch or cut anything that is touching the retina. So we try to lift it up using by manual surgery. First, to lift it in the middle of the eye, not touching the retina, and then I try to see how hard the lens is, to see if I can divide it and conquer it little by little, because I'm using the 23 for that purpose. And I see that this lens is very hard. And I decided to use from another port, not the port that I already had made, to use endofragmentation. By manual surgery, while sucking the lens in the middle, you can see how hard the lens is. I remove all the vitreous around it, and I'm trying to lift the lens again and doing by manual endophacoemulsification. This is another trick you have to do. You cannot use it without any cautious, because usually fragmentation would go through the nucleus and it doesn't cut it. So I'm using the left hand in order to rotate the lens around the phacoemulsification to hold it there, in order not to have a continuous suction and not to have an infusion suction difference, which is make a soft eye. And I wouldn't like to have that, because it's a bigger hole and a small infusion. So at the end, you can see that a lot of small fragments would be carefully removed, not to go behind the retina. And this way of first removing them, first lifting them, and then cutting them. And I don't care about if they go small bits and pieces hit the retina, because in 150 cases with this kind of Bissoff technique, as we call it, we never saw anything that hits the retina from above doing any damage to the retina. But we saw that every time everybody would touch something that is sitting on the retina would produce some hemorrhage or some tear. So the trick is never to touch the retina by trying to remove something. And we learn it from trauma cases, and we learn from drop nucleus. You can see that the hard nucleus is hitting the retina, but it doesn't produce any damage to this. And that you can see exactly, clinically you can see. We have the ABO system, as I told you before, so we can have 120 degrees, and you see all the bits and pieces that going in. So the most difficult part is to remove this lens without touching the retina in a detached eye, in a bullous detachment, inferior bullous detachment. And you can see that the macula is very nicely sitting there, no damage to this area. So it was a maternity of a nucleus through a hole from the back of the retina. I don't know if you had any cases yourself that the nucleus is subretinal. At the end, we clean completely the eye from small bits and pieces. And then the easiest part now is to do the retina detachment, because it's a fresh retina and it's not have any traction on that. So you're going to see that I'm going to go a little bit faster to finish it up. Chewing the last pieces with a 23 gauge port. And we use the force feeding technique. We just engage them, these small things, and with the other hand, we just push them in the mouth of the probe in order to get them easily, because it's a very, very hard lens. And at the end, we just use gas, air, and under air, we remove subretinal fluid on this area, and we flatten the retina inferiorly. So this was the easy part. and we got a very good result on that stick. But subretinal nucleus in such a big way. And the other thing is that we have a descimate detachment here while he was trying to remove. So we have to put it through a needle in order to prevent from bullosa the cornea. We just put the descimate back. So that's the surprise case. And I'm expecting to have ideas of how to do it.
Great. And before we call myself for the next case, my next case is so similar to this one that I would like to have a comment from Dr. Natarajan and Dr. David Shaw on this case. And after these discussions, I will introduce you my case. It's very similar, of course, in different times in the eye with some complications as well. And so I really appreciated and comment on your case that I would do. I like using the fragmentome a lot. You know, I learned using a fragmentome with the Acros back years ago in Toronto during my retinal fellowship. Dr. Berger was the one to teach me that. And I feel very comfortable using fragmentome. But of course, today, many doctors, they uncover the tip of the phaco emulsification tips, and they get away with that by using some PFO as well to lift it up, lift the lens up, and then they bring the lens also to the anterior segment and make things easier. But I don't like the idea, because I have the fragmentome. I think it's better, but it works very well with the phaco tip as well. And I use the appropriate power to get away with that very, very fast. And of course, we have to deal, as I will show you also in my case, we have to deal with the retinal detachment and maybe complications. And that's why I always tell the residents to be away from the macular area. And so in most of the cases, I like using perfluorocarbon liquids very early during the surgery, as long as I clean up the vitreous and core vitreous, and I insert the perfluorocarbon liquid so that the lens goes to the safer place. And this is a very cool case. I like the case. And interestingly, how the lens got inside the retina that way, you know, maybe due to some forces applied from the pressure from outside in, I don't know, but I think the way it escaped through that retinotomy, that maybe traumatic retinotomy, the way it went out was cool because it stayed peripherally, so spared the macula. Congratulations. And Dr. Shaw, would you like to comment on the Athanasios case?
Sure. So Athanasios, the cataract surgeon who did the case, were they doing a phaco?
Yeah.
And after the lens dropped, did they do a vitrectomy, an anterior vitrectomy?
No. They tried to get the lens with forceps and put it up and tried to invade the posterior pole without seeing what they were doing.
Seriously?
Yes, seriously. And the other thing they did is, in order to keep the nucleus up, they put an infusion maintainer not at the right position. So they put it far behind. So this infusion maintainer, the infusion thing, have been cut the retina at the area. And then whenever, I always try to teach them, whenever you drop something, take care of everything anteriorly to the iris, remove the vitreous, remove everything. And if you have a ledge, put a lens and leave it like that. Leave the eye soft. And don't inject Helon and Viscoat and everything, because all this stuff goes at the back of the eye. And then the next day you have a white cornea with 60 millimeters of pressure. So I tell them, just leave it there. Don't do anything.
Yeah, so I think that's it brings back memories for me of back when I was a resident at McGill, they were going through the process of, and Wai Ching was there. Wai Ching was with me there. I was a resident when the cataract surgeons on staff were converting from extra cap to phaco. And it was a very interesting time to be a trainee watching my staff struggle through their learning curve of becoming a phaco surgeon from extra cap. And I remember cases like what you just showed from extra cap when the cataract surgeons would get into trouble. And then I would watch them doing a dry vitrectomy, taking a Weck-Cell and a Westcott scissors and pulling vitreous and cutting. And I always used to kind of use these cases to kind of tell the cataract surgeon, stop messing with the vitreous. You guys, do your best just to clean the wound and then close the eye and get out of there, right? But that's a beautiful video to show cataract surgeons why they should never be messing around once they break the bag. Because, that shows you exactly what happens when cataract surgeons with no training start pulling and messing around on the vitreous. And I've never heard a cataract surgeon try to fish a nucleus out of the vitreous with a forceps and then put in an infusion line in the wrong place. That strikes me as obviously extremely aggressive. But it's a wonderful case to message to the general ophthalmology community. Don't ever mess like that. Don't be doing that.
Well, for a while, there has been a trend to do levitating the dislocated lens. And I think that this is just an example of those aggressive anterior segment surgeon trying to do too much without the awareness of the back of the eye. And I think the infusion, like that was said, was put in, probably infusing into the subretinal space and creating the retinal detachment in the first place. But there has been some very aggressive anterior segment surgeons showing off their levitating techniques. And this is a good case to show the consequence of misadventure.
Yes, exactly. That's the point. And it's not a dexterity exhibition. It's just that how far you can have a complication done because of trying to fish a nucleus out of the eye without having any experience on that. And the other point I would like to make to Hudson is that I have a bad experience with perfluorocarbon while you're removing the nucleus. Unfortunately, I still work in many places where we have a lot of young surgeons that they are trainees, and I got a huge amount of dropped nucleus that I have to remove every time. And whenever I use perfluorocarbon in the old days, the perfluorocarbon is sitting at the back of the nucleus, and the nucleus sitting on the top of perfluorocarbon, it doesn't touch the retina. That's correct. But as soon as you switch on the infusion line and you start doing a vitrectomy or a lesectomy or whatever, your phakiectomy or with the inside, then there is a turbulence inside the eye. And this turbulence is turning the perfluorocarbon all around the place, and the pieces of the nucleus you're cutting are sitting behind the perfluorocarbon, not because you put them behind the perfluorocarbon, and then with the turbulence, they go above the brakes, the small lens brakes, and they push them against the retina. And instead of protecting the retina, perfluorocarbon becomes like a blanket with the turbulence of the fluid that goes inside the eye, and it's covering. And it has a weight for the retina. Perfluorocarbon on top of a brake of a lens has a weight for the retina. And it produces some damage to the retina. So that's why I'm avoiding to use perfluorocarbon, because in the beginning it sits behind, and when you start, it sits on top. And that's my idea. But I'm sure that Hudson has another experience on that is not with me.
Yeah, maybe, I will show you in my next case, but before I comment on my case, I would like to ask Natarajan if he wants to comment on this case. And when I show you my case, you're going to see how big is the problem with perfluorocarbon to start with. And then I'm going to show you in a few minutes Natarajan,
No.
would like to comment?
Yes. No, in 91, one of the senior surgeon who started FACO, he actually pushed the lens to the vitreous and probably made a retinal tear, and the nucleus was in the submacular space. So when I was doing vitrectomy, I thought it was like ARMD scar. Then I realized it was the nucleus. So as Thanasis showed a beautiful case, I think you have to be extremely careful. Then I used two instruments, the brush and the other instrument, and took the lens from the subretinal space in front of the optic disc, and then as he did, made into pieces and removed it. And I think, as he rightly said, at that stage, if you use the perfluorocarbon liquid, it can go into the subretinal space. So I think then that's again, it will be a big mess if it is there on the subretinal space. So I think you have to anticipate the how this happen, and then I think we also have to sometimes learn not to use the perfluorocarbon liquid. And I think me and Thanasis were doing vitrectomy when the PFCL was not available. And I think that's how we can manage without PFCL, even though Stanley Chang and we attended the first PFCL meeting in Marburg. And
That's just for the history, to show how was the when nobody knew the perfluorocarbon. I got the first bottle of perfluorocarbon in Greece, and I was lifting the whole nucleus through perfluorocarbon, and I was taking it from the anterior chamber. And it was the first time that anybody has shown that in a meeting for trauma in Geneva in 1990 something. I don't remember,
92 in Geneva.
And yes, and then people from Hong Kong and from India, they show me doing that. And the name of Badrinath, if it means anything to you, he showed me doing that, and he asked me to go to Madras to show them how to remove lenses with perfluorocarbon. And it's very moving to me, because then I met Badrinath, who I think he is one of the greatest teachers ever that existed for retina. And that's how we meet now and then with Nataraja so many times. But I went to his place. So it's China and India that show me the way with perfluorocarbon. And now Stanley Chang hate me because I'm not using it anymore.
Have one of you tried to use viscoelastic instead of perfluorocarbon? It's work well sometimes. You make the fluor air exchange and you put the viscoelastic behind the lens, so you bring it up without this problem.
First of all, it dissolves very quickly, mixing with the fluid. And if it takes a little bit of time doing that, it's going to be just water. And the second thing with, you need a huge amount, which is not in a, usually they don't have it in 4 or 5 cc that you need to have. And if you forget anything inside the eye, because you don't see it, they don't have a difference of appearance with the interface of the fluid, and you leave some hilon or viscose at the back of the eye, the next day you have a very high pressure in the eye. So I really am afraid to use that. But I know people doing it in diabetics and in lenses and everything. But I'm really a bit scared to do that.
Yeah, when you do the
experience to do it, we should follow, yes.
But it's very interesting sometimes, because I have the same problem that you said about the fluorocarbon, and when you do the phaco with fluorocarbon behind, you have the turbulence.
Yes.
And this is a problem. So you can remove all the viscoelastic, because you do after you remove the nucleus, you use another air exchange. So you remove everything inside the eye.
Yeah.
It's one idea. It's not.
It's a good idea, but I was afraid to use it. When I used to be a fellow in the old days, they used to use a lot because they didn't have perfluorocarbon. They used a lot of viscoelastic, and I was doing my fellowship in Cambridge in Addenbrooke's with John Scott, and he was a super surgeon on everything, and he used a lot. And I saw a lot of hypertension of the eye after using this because they didn't remove it completely, as you said, through gas exchange at the time. So I was afraid since then, and sometimes if you have a bad experience, you just don't try to repeat it. But in your hands, I'm sure, and if you show me how, I can do it.
No, I use this kind of surgery when I have, like your case, some posterior rolls that you can use the fluorocarbon. The viscoelastic is very good for this because he doesn't go inside the under the retina. It's an idea.
It's an idea, and I respect that. I respect that.
Thank you. And before I call myself for my case, I will call Emmanuel Mavrikakis from Greece as well, because our friend Saad could not join us this time. He was on surgery. So he asked me to wait. Maybe he's going to show up by the end of the meeting. So Emmanuel, welcome. It's good to have you from Greece here. It's a great honor for us again. And you, Athanasios, you are the best for me, for us. And thank you very much for joining us and accepting our invitation.
Hi to everyone. Nice to see you again. Hudson, thank you so much for the invitation. It's been an honor being among such an esteemed panel. I will be presenting a case. You can see my screen. You can hear me, everybody. Yes, I hope.
Yes.
Okay. So this is a 69-year-old female who underwent uneventful cataract surgery in her left eye on April 1st, 2021. 2 days later, reported pain and redness in the left eye with reduced vision. She saw the same day her surgeon and diagnosed with endophthalmitis and referred to our hospital for further management on April the 4th. So in presentation, she had hand movements vision in that eye. The conjunctiva was injected. There was hypopia in the anterior chamber, a fibrin membrane on the posterior chamber intraocular lens. There was no red reflex, and the B-scan showed vitreous opacities, no PVD, and a flat retina. So the on-call staff of mine who was on the spot at that time, because at that day we were citywide on call, performed vitreous tap with Vanco and Amikacin. And of course, he sent the vitreous sample for cultures and sensitivities. So that was Thursday, the 4th of April. And then on Sunday, she underwent a second tap 48 hours later. So on Monday, the cultures came back positive for staph capitis, and the sensitivities were positive for vancomycin. And on Monday, the anterior chamber was clear, there was no hypopyon, but the vision was not improved, and she was referred to me for a vitreoretinal consult. So I organized the vitrectomy the next day. So this is the lady. As you can see, I performed a small little flap to initiate with a 23G needle to initiate the fibrous membrane on the lens, which was a step to help me perform a safer vitrectomy later. And then by using a 25G forceps, I tried to remove the fibrinous membrane, where you can see it's quite tough and very well adhere on the pupil margin. However, carefully and with a push and pull technique, I managed to remove it. Further on, I will grasp it from another point, because I was afraid also any very strong manipulation might damage the zonules or the capsule or the whole lens capsule segment, and then I will have more trouble. So I was trying to preserve the lens, the intraocular lens, and the bag, and the capsular bag. However, so here you can see that finally the membrane is removed, and those final strong attachments are released. And after removing it, just to make sure that I have taken all the bits and pieces, I just do high-speed anterior vitrectomy there. And then, so as you understand, this is the view of the back of the eye now. The vitreous is quite organized. So to me, there was no chance for this lady to see without the vitrectomy. Now, what is interesting here is that even though I am 500 vacuum and 5,000 cuts per minute, you can see that the vitreous, even though I go close to it, is not moving, is not coming to me. So obviously, the reason for this is that the lady doesn't have a PVD. So I do create a PVD and then things. So it is very important step to create an iatrogenic posterior vitreous detachment. And once it has been created, the vitreous skirt is lifted, and then you can safely remove as much vitreous as you can. And with scleral depression, I ended up with this superb, I think, result. And that is the end of the surgery by injecting a third dose of vancomycin. There was no breaks. As you can see, the lady was lucky. There was no retinal necrosis, and it is now almost coming to 1 month. The vision has improved to 20/60 from hand movements, and I think the key point here is that I think that the 2 injections of vancomycin and Beclin and amikacin that the colleagues did first day on the spot and 2 days later sterilized the eye and saved the retina, and then the vitrectomy was to remove all those opacities and give her sight back. Thank you so much for your attention, and I'm looking forward to Wei Qing's comments.
Congratulations, Emmanuel. And how is this patient doing so far? He's got clear.
I already said, Hudson, it is now coming to a month post-op, and the vision is 20/60. He sees flat, completely amazed and very grateful for what we did, because she had the initial vision hand movements. So superb result. I'm very happy.
Yeah, very good. And did you perform a OCT to see whether there is this?
Yes, I did. There is no CME. There is no cystoid macular edema or anything. The retina the macula is completely fine.
You did the culture of what you removed from the vitreous.
There was no need to do this, because as I explained already during my slides, the colleague who did the vitreous start day one so came positive for staph capitis, and there was not much point. Actually, to be honest with you, yes, I sent the whole vitreous bag to microbiology, but don't forget that the lady had already undergone 2 tap injections with vanco and amikacin. So any kind of result would be not reliable. So the first tap was the most reliable thing that we had. And we knew that she was sensitive to vanco. Thank you. Wei Jing, your comment.
Sure. I think your patient certainly should be very grateful to you, because I think you have given her vision back. I totally agree with you that the initial tap and inject are critical in controlling the infections. But I think that we are in the state that we should do the vitrectomy early in order to improve patients' visions. As you mentioned, the purpose of the vitrectomy is to clear the vitreous debris. It will not be possible for that vitreous to clear sufficiently to allow the patient to have meaningful visions. And I think you beautifully show the need for a PVD to successfully allowing a more complete removal of this very dense and cloudy vitreous. And the only comment I have, and not for you, but in general terms, is that when you do the vitrectomy, you just be a little bit more conservative. There's no need to try to trim every little bit in the periphery, because last thing you want to do is to inadvertently create a iatrogenic break. So in the case where there are retinal vasculitis or even retinal infiltrate, I think it's still good idea to create a PVD, because if you don't create a posterior vitreous detachment, the vitreous is never completely removed, and they become fibrotic or contracted and form membranous structures over the retinal surface. So I think seeing vasculitis in the retina should not be a reason that you don't do a PVD. I think PVD will be essential for the successful outcome of your case. And you've done beautifully. I think, like I said at the beginning, the patient should be truly grateful for your professional management of her.
May I ask you, by leaving a broad base of a vitreous skirt, you are not afraid that this might later create a retina detachment?
I think the key is to remove what is safe and not try to skirt and then and try to remove more than what is safe to do. So I think if you safety versus risk, I think the imbalance, especially when you have poor visions, and you show like taking time to remove the anterior fibrin membrane, and that was very helpful to allow you to have a better visualizations of the back. And otherwise, again, that will make surgery difficult. This is not your usual vitrectomy where everything is clear. This is a complicated vitrectomy when everything is blurred. And so I think safety should be an important concern, yeah.
Well, if I may, I'm always surprised with Wai-Ching Lam how deep he knows his retina. And I'm always surprised with Manolis on how good he's doing his job every time. So we agree in one subject that vitrectomy should be done in the endophthalmitis as quickly as possible if you have the access of the eye, because one day plays a little bit a role to that. But with Wai-Ching Lam, I have to agree with you. Riemann, a friend of ours, used to say that the retina from the toxins of the endophthalmitis and the reaction of the retina looks like the wet toilet paper. So it's a totally different kind to do a vitrectomy. This case that I saw Manolis was doing, the retina looks fairly nice when you removed everything. It doesn't have spots of white tissue, white membranes. It doesn't have the dots of hemorrhage. The toxins, because he was early, he didn't do a lot of damage. But if he's done a lot of damage, you have to remember that you don't go very close and you don't do a complete vitrectomy. This is the only time that I say you should not do a complete vitrectomy. Complete vitrectomy is much more dangerous than leaving it with a little more, because then you reduce the number of cells and then you use the antibiotics to fight the soldiers that you left there. So remember, wet toilet paper. I got bad experiences, but I always congratulate him because he has great ideas and he's a great surgeon, and I know him from close, and it was a great okay?
So I think I would go one step further. I think it's dangerous.
I was looking forward to this, David. Go.
Yeah, I was going to say, I think it's dangerous. Good to advocate highlight removal in every case. And I think, when I teach my fellows, when we do a vitrectomy for endophthalmitis, like Wai-Ching said, safety first. So I think Wai-Ching, you chose your words very carefully. You said when there's vasculitis, that should not be a contraindication to trying to pull off a hyaloid. You didn't say retinitis. So you avoided using the word retinitis. So like Athanasio said, if I look in there when I'm clearing through the vitreous and I see retinitis, the last thing I want to do is start tugging on a hyaloid and pull that off an area of retinitis, which is like wet toilet paper or whatever the phrases we use, rip the retina open, and now I've converted an endophthalmitis case into a break, a detachment, a gas bubble, and I'm going to have to dilute my antibiotics to stay out of trouble, right? So I think, I know a lot of people in our field like to message we should be doing a thorough vitrectomy on these endophthalmitis cases, but I'm a little nervous, or I think you have to use a lot of judgment and wisdom to decide how aggressive you're going to be on cases. Your case, like everybody said, the retina looked pretty darn good. So I don't think there's any issue there, and you show a beautiful case and a beautiful result. But I've also seen cases where people have been pulling a hyaloid and created breaks in endophthalmitis at other events, and that's nasty. You're creating a big problem for yourself when you do that, right? So I think you got to be careful, is I guess my only mission. I would not advocate pulling the hyaloid off routinely. I think if you can get it easily, okay, fantastic. If you're going to have any struggle with it, leave it.
Dr. Chow and Dr. Lam, in this, just carrying on your advice, the safety first measures, do you still advise vitreous tap in an endophthalmitis patient? Or do you directly jump into a vitrectomy or vitreous biopsy with a cutter?
I think it depends on how quickly you can get access to your operating room. And so in most places that I've been working, you don't get that quick an access. So I think if you can get the antibiotic into the patients, that's what the patient actually need. And then you can organize your surgery in a more timely fashion. So I think nowadays the approach for endophthalmitis is 2 steps. Get in to do your injections and tap and inject as quickly as you can manage the patient can. And that can be done in the clinic. You don't need to be doing that in the operating room. Then you then do the vitrectomy to clear the debris that is not going to be easily cleared in the next few days after the tap and inject.
Yeah, waiting, I agree, because the same in my hospital, we don't have a vitreoretinal surgeon on site all the time. So, but any staff member is able to do a tap and inject. So this is how we approach it in a two-step way, unless I am on duty that day, and then I will proceed to vitrectomy, but usually I'm not, yeah.
But I think your question is very valid because it's one thing what we do in reality, and it's another thing what the academics would say here. And I think I agree with what everybody's saying. The most important thing is get the antibiotic in right away. The quicker they get in, the better. But it would be very curious to have a study where everybody gets the antibiotics right away, and one group you immediately do the vitrectomy the next day or the day after, and the other group you just leave them alone and just let the antibiotics do their job and play out the normal course without surgery. But I don't think I've ever seen that study actually done, but it would kind of address the question you're asking academically.
All right. Really beautifully discussed case. And I will go back to the discussions on the case of dislocated lenses and talking to Athanasius about his case. I'm pretty concerned today about using perfluorocarbon liquids in every case. Of course, if we have the lens dislocated in the mid-vitreous, it's probably better if you can use and do core vitrectomy without using the PFO, but sometimes you use the PFO, and as you're gonna see in my case that I'm gonna share, you're gonna see that sometimes you get some surprises out of this, but still you can do a pretty good vitrectomy and save one. So can you see my screen? This is Brasilia, our capital. So I will start my video. Pode baixar. Patient is aphakic. Pode baixar mais. As you see here, as you see here, you see some vitreous attached. This is good imaging because here we have the dislocated lens is floating around, and it's been there for quite a while, this dislocated lens. So after some months, the patient decided to go to the ophthalmologist. Actually, it was not on the way, but after it was floating on the visual field, so he felt attracted to go and see the ophthalmologist. As you see here, now the vitreous, and everything seems to be very good. And so I'm trimming the vitreous around the lens. I did core vitrectomy. Everything seems to be okay. And after a while, I decided to use perfluorocarbon because I thought this thing floating on the macular area could not be so safe. So good idea to use perfluorocarbon liquids, but not very much. So I like using just a little bit, but even using a little bit of, I'm gonna freeze the image here, of using perfluorocarbon, you see some perfluorocarbon liquids, even though they are inside a good valid time for use, but sometimes they spread into so many bubbles. And if you let it happen, and sometimes you can get with some perfluorocarbon bubbles elsewhere that you don't want to see them. But in this case, fortunately, the bubbles became confluent and became to one. I used the fragmentome, and it was very easy to remove the lens. But I used the perfluorocarbon liquid just to lift the lens so I could have the macula safe and avoiding complications due to the vitrectomy and this lens hitting the macula as well. So it was pretty cool. The lens was not very tough to remove, but then I removed all perfluorocarbon very slowly. Sometimes we end up with some bubbles around, but we get the backflush cannula and remove it all. And this is interesting. I thought since the beginning of the surgery that this could well be the white without pressure. I said, what was that? Just a white without pressure, so I don't bother. I'm not worried about that. Then I would do maybe some thinning of the retina over there, so I would do some laser. But after a while, after I removed all the perfluorocarbon liquid, everything seemed to be very okay. And so I decided to appreciate the macular area, so it was so beautiful. I had this macular lens imaging. I was there sitting on the retina. And then I observed the area where the possible white without pressure was. And then I see the retina lifting there that way, and it was pretty much elevated. So I said, no, this is not a white without pressure. This is a retina detachment due to chronic adhesions from the lens on the retinal periphery. But then I decided to do a different approach. This is before I actually, after I did some laser around that area, but this, I put a bubble, air bubble, on the anterior segment. With that bubble, without using the lens, I could be, by twisting the eye sideways, the bubble makes a lens effect, so you can actually see that the area is very peripheral, that area of detachment is very peripheral. And this is me removing the bubble from the anterior segment. The patient is aphakic. So now I'm going to use the lens, the contact lens wide angle, and then I see, even though the retinal detachment is very peripheral, I did this barrier laser, and I noticed that the retina was pretty much detached. So as you see here in the far periphery down below, it's elevated. So I could not only do, maybe laser as a barrier to avoid the retinal detachment from going further, but then as I see here, the colorations of the retina, they are so brownish and pretty much elevated like this. I realized that this was a PVR, but the PVR just showed up because we removed the vitreous and there were no more adhesions on the retina, so it just popped up. And then I decided to do retinotomy because I couldn't do just the laser, so I did the retinotomy, and this is me here doing the laser in the far periphery. And decisions now is what to do. I removed all perfluorocarbon liquid. The retina looks flat, but should I use gas or should I use silicone oil? And this image is inverted. As you see here, the detachment is mostly superior. But then after doing the laser, I saw the edges and realized they were quite flat, were mobile. So I decided to go and do an air fluid exchange. So I started from the retinal periphery to avoid any slippage. And at the end of the case, you see here the air in the anterior chamber, the pressure got okay. We put some expansible, not very much, about 30% expansion gas, SF6, not to cause high pressure. And then the case got okay, and then I had the retina attached. But this was really tough and difficult decisions because I saw the retinal detachment at the very retinal periphery, and then I said, should I do laser or silicone oil, or should I do silicone oil or only gas, or should I do retinotomy or not? But after I saw the elevated edges from the retina, I did not think twice. So I had to do this relief retinotomy at the very periphery. And that's what I was commenting, Athanasios. These are tricky cases. You had this retinotomy, but you know the lens got inside the subretinal. But in this way, I had to do it because otherwise I could have a retinal detachment afterwards. So I decided to go ahead and do retinotomy, gas, and it went okay like that. Thank you very much. And for this case, we have Athanasios' comment. Saad Wahib is not there yet. I don't know whether he's going to make it or not. And Athanasios and Vaibhav Sethi to comment. Athanasios, you could go first because your case was similar to mine.
Well, I like very much your technique, and also I would like to ask you what kind of, it was the whole lens. It was like a Marfan syndrome or whatever, that the whole lens. It was not during a cataract that is done. It was an ectopic lens that was it, how old was the patient? How old?
The patient was not very old. It was 56 or 55. And he had this dislocated lens. And you see that they started doing the phaco, and after you started doing the vitrectomy, you see they started actually to do the phaco. You see some, I think they started the technique, the divide and conquer, because they just started. I don't know what happened. Maybe it was performed for a resident, and but you know, everything was just dropped at the posterior fundus, and it was not very tough. The lens was the easiest.
The lens was not, but the reason when you start the cataract and you have a retinal detachment at 12 o'clock, it's in and out. The vitreous cutter, when you, or the fragmentome, if it goes in and out at 12 o'clock, but you usually do that, especially when you have a lens like that is already dislocated, you might push things together, all because the fibers of the lens are getting into the vitreous base. It's a complicated thing. The vitreous base goes up to 8 millimeters. Sometimes the vitreous base is even further to the equator than usually. So when you go and do something that the lens is going downwards, and you push the lens in order to cut it, you push it, you push it, you push it, then you create a tear. You create some damage to the periphery. But it was very nicely the way you did it. And what I said about perfluorocarbon was not that you can't remove it at the end. You removed it beautifully. That's why we're using perfluoroctane, because sometimes even if you leave a bubble, it can go away. But the issue is that when you got pieces sitting on the retina and then the perfluorocarbon goes above them, that's why perfluorocarbon is doing some bad thing. But in your case, it was beautifully done. And did you put a lens at the end or not?
No, not
I don't
yet.
think you put a lens.
Not yet.
You just leave it like
waiting
that.
for some
Okay,
time.
then you can suture a lens, or you put a...
But interesting, as you said, as you commented on the perfluorocarbon, it was not very easy to remove it all, even though I put only a little bit to lift the lens off the macular area. But at the end, I have to search for small bubbles of fluorocarbon liquid with the backflash cannula all around, you know, one here, one there, and
It goes anywhere you move the eye, and it goes anywhere in the opposite position. It goes and hides, especially when it becomes a small bubble. And the problem with the perfluorocarbon, that's why they try to make a color one or something like that, because they don't have a surface difference between the fluid and the perfluorocarbon sometimes, and you don't see it. But it doesn't produce a lot of trouble if you leave a couple of bubbles. Only the other day, the patient would say, I have some bubbles moving about. And I don't know, what kind of perfluorocarbon liquid you use? Perfluoroctane, perfluorocarbon, whatever. What kind?
We use
Decaline?
We use the one from Ophthalmics here, and the French one, I guess, from Doric, I'm not quite sure. And we
Oh,
used
dope.
the French one and the Brazilian one here. This one was from Ophthalmics here, company here in Brazil. I guess Ophthalmics, André Jucá, the name of the company in Brazil. I can't hear you.
Okay.
Yeah, I can hear you. I have nothing else to say because it was a beautiful surgery, and I loved it.
Thank you very much. Ophthalmos, yeah, that's the name. Not easy. You have to search for these bubbles everywhere. Vahab Seti, do you have comments on that?
Yeah.
No,
Can I say something?
Sure, go ahead.
Hudson, I think one very good surgery. Congratulations. Another way, if you have 120 gauge knife, you can fix the lens before you, in the same place that it was before. You introduce the knife inside the lens, and you can remove it, fixing it, and he doesn't go to the fundus, to the bottom of the eye. One idea.
Yeah, good idea. But this was already around, moving around the eye. The patient was not so symptomatic. But then it got on the visual area, and then, he took so long. And I think the lesions in the far periphery are due to chronic retinal lesions due to the movement from in the contact of the lens to the peripheral retina. And that's what my thought was. And so after doing the complete vitrectomy, and I saw there is no hole here, but there is a traction over there, and there is a lesion intraretinally, and the retina is raised. So why not to do a local retinotomy, because otherwise the thing could be lifted, and the laser could not work enough, and then we could have the tractional component of the detachment, and then things could get worse. So that's why I decided to go very peripheral and see that. And that maneuver is interesting when you have air at the anterior chamber, and then through air without the lens, you can move the eye sideways and you see the far periphery. This was interesting view.
In the past, we used this bubble because we don't have good lenses. So I'm very old, and I started the vitrectomy in 1980. So I used the bubble many times.
Good idea. It gives you a good view.
Dr. Artson, a very well managed case, really very interesting. Just one question I had, why did you choose gas over oil in such a aphakic patient? So, I mean, what should be the tricks that you think a person should follow in putting a gas? Because would that be an adequate tamponade in such a case with the aphakic, there's no lens, there's no diaphragm there?
Yeah, I had these tough decisions because we thought, should we use gas or should we use oil? But because it was peripheral and superior and temporal, so I think the best gas was to use gas. And also the gas, also the periphery got pretty flattened after we did the exchange from the periphery to the center. And then I observed everything was okay. And usually sometimes, not this case because I had done enough lasers around the retinal periphery, I usually like, even if it's gas or silicone oil, I like to take a good look at the retinal periphery to see whether it's flattened or not. And interestingly, when you use a wide-angle vitrectomy lens, the contact lens that I like to use more, you go and see the retinal periphery much better, much far the retinal periphery when you have the gas inside the eye. So at the end of the surgery, I usually put the lens and observe. And in some cases, I like doing laser under air. If the patient is, doesn't have cataract or the patient has clear media, it's very good to do laser under air. But this case, I decided not to put silicone oil because it's attached.
And superior, right? The rupture.
Yeah,
but have you seen
superior and supratemporal.
can the gas come into the anterior chamber in such a situation with AFAK here? I mean, what do you call the pupillary block and a secondary angle closure problem? So, I mean, is putting gas in an AFAK patient a routine procedure protocol by the panelists here? Would you recommend in a retinal detachment or in such a situation putting gas versus oil in AFAK patients? That's my question.
Yeah, I think it could not be an issue because if you have air, but this, I don't use too much gas. So even though the gas could be in the anterior chamber, it won't last much because I usually, for these cases, I like 25% or 30% concentration, so it wouldn't stay there for a long time. And I think at the beginning it's okay that you see the whole thing through air, and it's good to follow the retina. And as long as I have half the gas, at least for 1 week or 10 days, 50% gas inside the eye, and that I keep following, it's going up and the retina is attached, I feel comfortable. And of course, if we detect anything before that, we could take the patient to the OR as soon as possible and do in the PVR and do laser and silicone oil. So
sorry to interrupt again, but silicone oil is out of the question for this simple upper detachment. I wouldn't put silicone oil at all. And the gas bubble you put is very safe if you put it also in the anterior chamber and posterior chamber at the same time. So if you fill the eye anteriorly and posteriorly, it will stay like that and it wouldn't make a block. And if you like to be on the safe side, you just make a peripheral iridectomy at 12 o'clock for the fluid, because in every complicated case, you need to have this. But already, because you have already done vitrectomy, you don't have that problem. So when it's aphakic, without anything else, you can put gas in both chambers at the same time, and it wouldn't be any problem.
Yeah, I think it's okay. If it was silicone oil, maybe perhaps I would better doing inferior.
Why silicone oil? Why?
Maybe the silicone oil could push on the iris and give block, and because of adhesions from the silicone oil, and sometimes the silicone oil could go through aphakic patients. And so it would stick their iris and could give you a block. But I usually don't have these cases, and even if it's silicone oil, I don't usually do inferior rhidotomy because I end the case, I do direct exchange, and by the end of the case, the silicone oil is filled up to the ora serrata, so it doesn't go through the anterior, through the anterior chamber. So it doesn't cause me a problem. But then if you have, during the surgery, if you put too much silicone oil, and then you have a silicone oil in the anterior chamber, and it gets sticky, and then could be a problem. But after surgery, even if it's gas or silicone oil, mainly in aphakic patients or in pseudophakic, but especially aphakic patients with silicone oil, I put them face down. I stress, I emphasize that the position face down is very important. So the silicone oil goes beautifully at the posterior pole and doesn't give you a problem.
It's the iris, it's protecting it. It's going to stay behind if you doesn't have overfill, if you don't have overfill. And the most important thing is if you have an aphakic eye, you should do a 6 o'clock iridectomy. Ando 6 o'clock iridectomy, because he's sitting up and the fluid goes at 6 o'clock. So that's why you don't have a blockage.
Yeah.
So remember, 6 o'clock iridectomy, and you can do it with a cutter. You can make it slow to cut 100 cuts per minute, 650 section. You just touch the iris, you do a few cuts, and you got a 6 o'clock iridectomy before you put silicone oil inside. The different silicone oil would go in the anterior chamber only if you lower the pressure in the anterior chamber. If you have lower pressure in the anterior chamber and higher pressure in the posterior chamber, then they bend to go all together in the anterior chamber. So if you know this fluidics of the silicone oil, you don't have any troubles putting silicone oil in the eye without being aphakic. We used to do it a lot, and in the old days, and we never had trouble until Ando came from Japan and showed us the 6 o'clock iridectomy, and we saved a lot of hypertension in these patients. And I'm sure you know you have a lot of work to do, and it was. But in this particular case, I don't think the use of silicone oil. I think gas was the perfect choice that you make, and that's why you get a perfect result.
Yeah, thank you. Thank you. And also, because repeating that, I like to do, in case if I use silicone oil, I like to do the direct exchange, then I would fill up the perfluorocarbon liquid up to Eurocerrata. And then with the air fluid exchange, I mean the direct silicone oil and perfluorocarbon exchange.
What kind of machine you have? What kind of vitrectomy machine you have? Dork?
What is that?
What kind of vitrectomy machine you have? Dork,
Constellation and Stellaris. We use both. Yeah.
Stellaris.
Yes, Stellaris as well. But this case we did with the Constellation.
Constellation.
Sometimes we
Constellation has a trick. I don't know if you know it. Constellation is a dual foot petal. That means that if you have an infusion line on one hand and you inject silicone oil, and on the other hand, if you hold the fluid needle and you can inject silicone oil directly in the eye with perfluorocarbon, and half of the petal goes and you inject silicone oil. And if you push the petal towards down, another half down, then you remove silicone oil with energetic suction from the fluid needle. So from one hand, you put silicone oil, from the other hand, you remove perfluorocarbon. And you do it controlled. That means that if you have more perfluorocarbon that you have put, you just lift your foot petal from the gas and you let the silicone oil get it in and complete the fill. If you have overfilled the silicone oil, you put the gas until the end of it, and then your fluid needle is removing everything. But you need to have a chandelier light to do that because you need two hands. But this ask people from Constellation to show you this double function, extrusion and infusion, to do a direct exchange without much trouble.
Great tip, yeah.
It's a great tip for the Constellation. Not many people know it, and the people from Alcon don't know that.
Yeah, maybe not. And
very interesting.
If you could send us some articles, Athanasius, on that, or some tips or some videos, this is great to know. I'm going to apply that.
This is what this all about is, because if you don't find them in the books. What you're showing us, the session that you're doing is beautiful, and I love it every time I see it, because it's all about tips for things that you cannot read them in the internet and you don't find them in the books. And one of the greatest teachers that I had was David Cho and Wai-Chi Lam. Those two people are the wisdom of retina all the time, because they did a lot of work, and they don't have to support their work with profit, because it's for free to do retina surgery in Toronto. You don't have to pay. So they're doing a lot of cases, and they think correctly. So I love what you're doing, and keep doing it. This is the whole thing about tips that you cannot find in the internet or in the book. And congratulations again for the whole effort.
Thank you, Athanasius. And I would like to call now Nageswar for presenting his case. If you have your case, you can share it. But if you want me to share, I will share it for you. Are you ready, Nageswar?
Yes. Can you see my screen? Hello?
Yeah, it's perfect.
Okay. Today I'll be sharing my 3 advanced PDR cases, proliferative diabetic vitrectomy. And the first case is, it's a thick membrane with a postupral detachment. It was, and it's a very tough fibrovascular proliferation. I use 25 gauge vitrectomy. Always I use, because I stopped using 23. And this is the way I dissected. This is the I have constellation. So in that we have the professional reflex, which is actually very good tool. And in fact, we can use that so that it makes the membrane very nicely lift. It gets lifted from the retina by pushing the fluid underneath the. It actually pushes the bouts of fluid. So very neatly it actually dissects. And what Dr. David said, today's this one, all modified cutters, they have very close to the ports are very close to the tip, and they are beveled, so we can go very close to the retina and dissect. That may be the reason. So less trauma you will induce at the retina, and selectively, because of this advantage of the cutters, we can go very close to, and we don't want the retina to be cut, and the unwanted tissue may be removed very easily. This is the way I did this case. And in fact, luckily there was no much of bleed. And with this, in fact, I did not use here bimanual, the single hand only. And the case 2 is, it's a combined attachment. It's even a little more complicated. The membranes were very thick. So I had to, here in fact, we could have, I could have actually gone with the bimanual, but somehow with this, so this thick fibrous condition which is attached to the peripheral retina at the equatorial level, it was very sticky to the underlying retina, and I had to do a few purposefully retinotomies. The thick fibroscular tissue which was there, epicenters were there. I did this one retinotomies to flatten the retina, and eventually the lasers and silicone oil injected. In case 3 is, it's a bit simple actually, premacular hemorrhage, subyloid hemorrhage with inducing PVD. The case could go easily, but as after clearing the hemorrhage, I noticed that the macula is bit, it's a small hole was there. I had to do a membrane peeling, this one, ILM peeling. So my question is here, although the techniques and technology had changed, we learned so much actually in diabetic cases, diabetic vitrectomy, and the technologies and the instrumentation which has actually improvised a lot for the betterment of the results. But still, I find this rebleeds. Maybe all of us maybe this one encountering these issues. Rebleed is a universal problem. So how often we see? That is what my question. And how you can prevent this rebleed. And second is ILM peeling in PDR. What is this one indication, or in PDR cases how it is better to remove the ILM over the macula?
Dr. Howe, let me ask you something. The macula was attached with the membrane when you start the surgery or not? Or you don't know?
Which one?
The macula. The macula was attached.
In which case? Third case?
Yes.
Third case it was attached. Only that there was I found after clearing the premacular hemorrhage, I found there is macular hole.
What I think is that the hyaloid is very adherent to the retina in this case. This is maybe a young patient, isn't it? A young? How old is him?
He is around 55.
55. The idea that I have used in the last case is don't remove all the membrane, because you unfortunately you do rolls. In all the cases you make rolls and you traction all the retina. If the macula is almost attached or is attached, I think I remove just the membrane until the vessel, the arcade of the vessel is enough. Just the macula. You leave the macula attached and leave all the rest of the membrane. This is my idea, and I use so much, and I think it's better vision because you don't agree so much the retina. You don't use silicone oil too. So I prefer to just do the localized surgery just in the macula, if possible, of course. Because if you see this case, the retina is established, it's stabilized for many years of the retina, diabetic retina, but the macula sometimes is attached with the membrane or some traction. In the last times, I used just remove this membrane over the macula, just to make a little better the vision of the patient. Because you don't have bleeding, you don't have retina rolls, you don't use silicone oil, anything.
First and second case, the retina was detached. So in that case, actually the silicone oil, it was needed. But in the third case, which I showed, that is premacular hemorrhage, there you don't need to put any oil.
Can you put in the start of your video, in the start of your video? If you see here, if you can stop the video, just when you, here, you see if you continue to just open the macula with your vitreous cutter, you can just open and leave the macula open, without the membrane. Maybe it's attached. So my idea is just cut in the central retina. Don't need to remove the periphery, everything, and cut the retina. The retina is, you don't worry about it, You need the macula working.
Okay.
So I decide, in the last case I do, is just remove the central membrane. Just this, don't anything, don't change, don't vitreal exchange, nothing. Just cut over the macula and finish the surgery. This is my idea.
Okay.
That was cool, and I think you beautifully removed, as I comment on the chat, these with this technique, with the cutter, and trying to relieve as much as possible. I had quite a few cases for diabetic retinal detachment, vitrectomy, and then what I'd like to do is almost always I do that, is that I use the cautery whenever it's possible to do the cauterization before removing the membranes. But if I find the right membrane and it goes away easily, like this one, this first one you showed us, that and free up the macular area, and that's good. And the point that George Dimitri says is that when we remove the membrane from the macula is free, and that's, for me, that's the most important thing. And then I will decide whether to relieve around the periphery and things, and end up the case with silicone oil. But I liked your cases, and especially when you stained with the brilliant blue, you got a very beautiful view from the posterior pole. Congratulations.
Yeah, very good.
And
yes. Just a comment about that some people, and there's been more and more people doing that, is preoperatively give some anti-VEGF that can help to reduce intraoperative bleeding. Of course, you want to do it within a few days from the time of your surgery, so that to avoid any progressions of that tractional fibrosis that may develop following the anti-VEGF. But that could help to reduce intraoperative and postoperative bleeding that you might have during the management of this diabetic tractional detachment or membranes.
Well,
whatever the rebleed, post-operative rebleed.
Okay, Athanasius.
Dr. Kishwar, I like very much your presentation because you're using the thing that we taught in EVRS so many years ago, that by manual surgery or single use in manual surgery without scissors. So you're using the benefit 25, the way that Carlo used to say, the benefit of this, using to delaminate or doing anything with your vitrectomy probe. And it's a very soft and nice surgery. Unfortunately, the idea of keeping the macula on and forget about the periphery, it might apply in cases where you don't have traction and you don't have tears, because the peripheral traction with ischemia are going to go further and further, and probably they hold some new vascularization in the top of the traction. So if you leave it without, and if you do any laser, you're going to make more traction to that. And also, if you have a tear at the periphery or in the center, you need to remove all the traction around the tear. Then you don't have any fluid going behind, and you don't have a detachment. So I think it applies, the macula leaving the rest of the, applies only if you don't have traction, if you don't have the neovascularization, and if you don't have a tear. Otherwise, I would go with your idea of using it as a scissor and use the tip of the 25. I'm using 27 now, as you saw in my case, but I'm using 27. But congratulations. And also, what kind of viewing system you got? I need to learn. What kind of viewing system?
I have Zeiss Resight.
What?
Zeiss Resight.
Resight. Okay.
Resight.
With a fine focusing on the foot pedal.
Yes, sir.
Okay, that's good. That's good. Thank you very much, because you get a beautiful view of the videos.
Thank you, sir.
I'd like to have good videos with aphakic patients.
André Jucá, do you want to comment on Nageswarer case?
Yeah, just to say it's really a nice case, and just well done, but it's really tough. I do agree that anti-VEGF may help in avoiding bleeding. Thank you.
Good, good. And we are coming to the end. We have George Mitri and Vaia Pepsetti. George Mitri, are you ready for your case?
Yes, I am.
Great cases.
Just one comment about this last case. I use this technique only when, like this case, that you have a lot of fibrosis. The retina is stabilized in this kind of diabetes. Some case that you have a lot of new vascularization, of course you have to stabilize the retina before, but in this case, it's a lot of fibrosis. Don't will happen anything to the periphery anymore. I think that liberation, just the macula, is a very easy surgery and with good results. Well, anyway, let me show my case. Well, are you look? Everybody seeing?
No, not yet.
Everybody seeing?
No,
yeah?
It's not
Oh.
yet. Not yet there. Let me see if you are co-host.
Let me see.
Yeah, you are co-host. didn't. Yeah, now it's okay.
You
now.
got it?
All right.
All right?
Yeah, sure. Good image.
Okay.
If you wanna enlarge
Let's
it.
see. It's a fine. Okay, this is a case of a woman, 79 years old. She complained in the left eye of visual clotting for 30 days. In the right eye, she had many years ago a macular roll. Can you see here? And the left eye, she had this membrane, white color, and the vision is 20/40. Is only one eye working, right? So we did the exam. And during the fluorescein, you can see 2 points of leaking, here and here, okay? This is first, and after that appeared one in the macula. After 10 years, she come back, 2 weeks, excuse me, and the membrane was dissolved in the vitreous. And I imagine that it's a tox or something like this. So the IEGG is 1 for 65, IgM negative, low is negative, TB negative. At this point, I would like to discuss with the other participant. What do you think about? What do you think is this?
No vitreous cells. The vitreous is clear.
Yeah, this membrane in the vitreous. So the color is yellow to white. But she came to my office after 30 days when she felt the symptoms.
Did you get an OCT?
Yes, I do have. This is the OCT. No, what my doubt is, this is a uveitis or what is? This is a vitreotraction. What produced this opacity?
It looks like a polypoidal hemorrhage.
Yeah. Other opinion?
Looks like from OCT, the vitreous is sitting on that area, but I'm not quite so sure because I had the cut from the OCT is small enough. And
yeah,
where this leakage could be from? Maybe cystic intraretinally, because I don't see from the profile of the OCT, I don't see intraretinal OCT changes.
Yeah. Let me show you something. I was very doubt about this case. So this patient was in my office since 2008. And this case is at the end of 2019. So I checked the OCT, old OCT, and what I said, the right eye is the same, and the left eye, I see the partial detachment. You look, the macula is attached, the hyaloid is attached, but in the nasal part, it is adherent to close to the optical nerve. And I don't worry about this. The patient is 20/30, it's everything okay. So in 2009, I see the same thing. You see these 2 points of adherence of the vitreous. In 2014 and 2013, the retina is starting to to change this anatomy. You check here. The hyaloid looks like traction in this point. And you see here in the right side in high.
This now
high
looks like
amen.
attachment.
Yeah.
This now looks like attachment.
Yeah.
Is pretty
Yes.
much our subject in our.
So in my idea, this is what happened with the time. So now in 2019, she is very traction. So this produced a little hemorrhage, a little bleeding. And this bleeding is caused by this other adherence that never was for all time. It's until now it's traction. For this reason, it's appear in the fluorescein. So in this case, I removed the vitreous. I will show you. You can see the membranes attaching to the macula. So I use the membrane blue just to see the membrane better. So you see the 2 points of attachment. So I just removed the vitreous. This is the surgery. I don't remove the hyaloid, anything, just the vitreous. Because this is the only eye the patient see. So I prefer don't touch so much the retina. So you see the points of adherence. And after the surgery, a reminiscent edema you can see here 2 months later, but the vision now is 20/40. And the patients, what happened? Sometimes appear the edema, and I use the corticoid, sometimes intraocular, and sometimes she doesn't have. So this is the final result. And she has one pad, one PED, and this is the case to discuss. It's not normal. The vitreous continues attached in the retina between the disc and the fovea. So this case simulates one polypoid or a uveitis, something like toxoplasmosis, and it was just one traction. For this reason, I bring the case to discuss.
Great case, Dr. Mirti. I like doing early vitrectomies for those cases, especially when you observe and you are following up the patient and that's the only eye, and she's being okay, but after a while the vision dropped and there's hemorrhage. So I love these, pictures from OCTs, from tractions, and you have to know when to intervene and go ahead and do a vitrectomy. Like this case, you didn't wait too much and saved the patient's visual acuity and eye. Congratulations.
Thank you.
Nageswara, want to ask Dr. Mitri anything?
No. Nothing to say. It is very nice. Saraj actually, he has kept very nice documentation is very good. That one should learn from him. Very neatly. Last time also he showed very good documentation. That is what actually we learned from him. Nice and good.
Thank you.
Which OCT you use, Jorge? It's pretty good.
This is a Heidelberg.
Heidelberg.
Yeah.
Pretty good images, yeah.
Yeah.
And to finish, wrap up our cases, our meeting, that was really awesome. I'm learning a lot. I'm being very sincere. I'm learning a lot with you guys. And very interesting cases, especially as Athanasius said, many cases, many things are, tips from what we learn from others that we do not find in books. So it's interesting that we learn like that too. And I would like to call Vibhapseti. Vibhapseti, you are the last but not the least on our list, but you know that after this, I'm gonna ask you to close, after you present your case in our discussions, this Retinawesome 9 that was really cool. And it's been 1 year. Next Tuesday, we're going to be 1 year into Retinawesome. So I will give you the task of showing your case and also closing the event afterwards. Thank you very much and welcome.
Thank you, sir. Thank you so much. Can you make me the co-host for Dotson?
Sure. I thought you were, but you left and you joined later on again, no?
Yes.
Okay. Yeah. It's okay now.
Great. Can you see my screen?
Yeah, pretty good.
Yes. Last but not the least, I'll be presenting another modification of what Dr. Andre Juga presented, the first case, that is the X-knit cell-fixated IOL technique. This is an extraocular needle-guided haptic cell-fixation technique, popularized by the Arvind Eye Care Group in south of India. So it's basically, this is an elderly female who had a dislocated lens and a bag. So already what I've done here is I've made my 3 ports and I've made a stellar tunnel. So now I go inside and bring up the IOL and the bag into the anterior chamber, open up the stellar tunnel, and after that explant the IOL and the bag because it was dangling in the anterior vitreous cavity. So the other thing also I've done is I've made 2 180-degree, I've just marked them, as well as what I've done here is 1.5 millimeter from the limbus, 180-degree apart. I made 2 tunnels, 2 stellar tunnels with 23 gauge MVR blade parallel to the sclera. In this, a stellar tunnel, a pocket here and a pocket on the other side, which you will be seeing soon. So now this is the IOL that I took out. I did thorough vitrectomy, anterior vitrectomy, as well as indentation and proper vitreous removal. And after I had removed the complete vitreous. This is the X-knit needle that is comes for around $10. So it has 2 marks, a 1.5 millimeter mark and a 4 millimeter mark. The 4 millimeter mark is for the length of the stellar tunnel, and the 1.5 millimeter mark is for the entry of the needle. So after marking, this is the needle. It's a bent 26 gauge needle at 60 degrees, and it has a soft silicone kind of a hold. So after you enter into the eye, with the help of McPherson or any instrument, you externalize the first side outside. Now you hold a non-foldable 3-piece IOL and track the haptic into the 26 gauge needle very comfortably. After you put an adequate amount of the haptic, now with the help of both the hands, you slowly, gently bring inside the optic and just keep the other trailing haptic outside, and at the same time bring out the first haptic. And this silicone tip really helps a lot, because what this does is when you bring out the haptic, this gives a nice firm hold. The other thing now you're supposed to do is we just release the tip slightly so that there's more amount of maneuvering of the optic and the trailing haptics. Now the same thing happens on the other side. You come out through the tunnel and with the help of the person, track the haptic again through the other side, 180 degree apart, and just gently, very slowly come out and bring out the haptic. So now this was only possible because the other side was very nicely, firmly held by the silicone soft tip. So now with the help of lens holding forceps, the haptic are fixated into the pre-made scleral tracts on both the sides. So again, holding the tip of the haptic and engaging it into the opening of the scleral tunnel very gently, using the other hand as well, and just going into the tunnel and opening up the forceps and coming out. And this was the final outcome of the surgery. This is the 1 month post-operative outcome where the IOL was well centered, and this is the associated picture of the showing the haptic in the sclera and near the angle, this area. Thank you very much.
Congratulations. Good to see those OCTs showing the haptic this way. I haven't seen those images. I don't see them very often. And I would like to ask Dr. Lam if he wants to comment on your case.
Very nice, very nice technique and interesting instrument that you have. Is that a something I didn't know about this XNet?
XNet.
Yeah.
It's basically a bent needle with a silicone soft stopper.
Yeah.
So a lot of doctors were using the silicone, the belt buckle band, and kind of fixating the haptic there. So now what the Orolab, they're the largest manufacturer of instruments in India. They have come up with a very simple way. It costs around $10. There are 2 needles they give you, and it has a soft tip. So basically, you don't need an assistant to hold the haptic. You just go in, and when you come out, the haptic is through and through the soft stopper. So you very easily just externalize both the haptics, because that is the toughest step in scleral fixation IOL, because you can mess around with the handshake technique. And in this case, even if there's a corneal opacity or corneal edema, you can still very well place a IOL because you don't require any intraocular maneuvers. Everything is outside the eye. You track both the haptics outside the eye and you bring them externalized very safely and effectively.
Yeah. No, it's very clever designed, and it looks like because your needle need to come out of the wound, having a infusion is probably very important to maintain the integrity or the volume of the eye. Yeah.
This was the first case I did, and I was having difficulty, as you were saying. The globe slightly collapsed because as the tunnel opened up, the pressure came down, and that was the one issue I faced, hypotony, during the externalization of the haptics.
Yeah, and it's a nice technique that you do, feeding the haptic into the scleral tunnel that you make with the MVL knife. You said, right? Is that what you did? Yeah. And sometimes I found that it's not so easy to find the tunnel back afterwards, because you don't have marking on the tissues, and after the surgery, the tissue get a little edematous, and the tunnel that you created with the MVL knife may be difficult to find, and those haptics are very easily bendable, and you can make it difficult to once it bends, it'll be difficult to insert. But nice, no, it's very clever, very well executed technique. It's good to have that needle to help.
Thank you.
Clever thing about the silicone sleeve to trap the haptic.
Good, John. Can I ask the first and the last presentation to have the emails so I can have the details, because suturing the body of the lens for a broken haptic, it's very nice, the first presentation. And the last presentation, I would like to congratulate because you do an open sky Yamani technique. That's the difference. You just open the eye. Of course, the issue of the Yamani and the whole vitrectomy area and the 25 gauge is not to open the eye. So, because there's less flow, less everything without opening the eye. But if you have to insert a new lens, your idea is great. So I need some information on how to do it myself. I need the needles because there are not only one way. And for example, they say that the tunnel that Wai Ching Lam is talking about, I never make a tunnel when I'm externalizing the haptics. I first externalize the haptics because I'm not 108 degrees all the time. Then I hold the haptics like a wheel and I try to adjust the lens into a position. So one haptic might be more outside than the other haptic because you never 100%. Then at the edge of the haptic, I put the needle and I make a hole, just a little tiny hole, to hold only the tip of the haptic. So I make the small tunnel at the end of the haptic extrusion, not before. So I don't have pre-placed tunnels because pre-placed tunnels can give you different length of the haptics. So you have the lens sideways, not in the center of the eye. And last but not least, does anybody know the Carlevale lens?
I've seen the video.
Carlevale lens. When you open the eye and you have to put a lens inside, you have two choices except yours. Either you put an iris fixated lens or a Carlevale. Carlevale lens is a lens that has two anchors vertically to the lens. So you make a vertical opening in the side of the eye, you take it out, and because it's elastic, you can put the angles and that's it. So it's growing very, very much. If you have to use another lens, it's growing very much the Carlevale lens. And take it in consideration because it's a competitor of you. But generally, I like all the different situations because you never know which eye and which way you should do it. I just don't stick to one situation. The only thing I hate is suture lenses. Suture lenses, very bad experience. We started with them in the 90s, and we have very bad complications later on, retinal detachment, tilted lenses, and all that stuff. The old kind of suture lenses, not the new kind that is to the haptic. That's why I agree with Wai Chi Lam that the plane, when you got just two things, you have to stress so much the sutures that the lens should not go sideways with just two lenses. But your technique is wonderful, and the technique is very good because it can be applied to surgeons that are cataract surgeons and they don't have a lot of dexterity that you do it with Yamani. So it's applicable to a lot of people. So please send me the needles, send me the video, and I promise you I'm going to pursue that in Greece. We have many, many, many patients in Greece, 100 or 150 patients, something like that. It's like India. Yes, when we went to India, they say, how many people you have in Greece? I said, how many people? And they asked me, which hotel they stay. For you, it's just a small town.
All right, and now the last comment from Dr. Natarajan. Are you still around, Natarajan?
He has his beauty now.
Yeah.
Nataraja is taking care of his skin, of his eyes, of everything.
Yeah,
I told you, he's in my age. We're together. And people say he's my son. I don't know what kind of... He should give a lecture of how he keep up like that.
That's true. That's true. So Webhub, would you like to? I was actually, your father was asking about your lecture here, and he just sent a picture from China participating into meeting right now, and I said, no, Webhub's now here to close the event, but if you want to show up, just to say goodbye, and I would like you to say some words and close and wrap up our event. Webhub.
It's 9 o'clock, and Retinawesome 9 has come to an end, and Retinawesome has been along since COVID. The time the inception has started, and it's been one full year. And all thanks to Dr. Hudson and the team of Retinawesome keeps going every meet. And right now, India is facing the second wave, which is the worst wave we've ever faced. So it's going to be in lockdown, complete lockdown right now, and every state is having thousands of cases coming up. So there's this new mutant virus coming in. There's a double mutation to it. There's a UK strain also coming in. So it's going to be tough times ahead for us, but hopefully we'll sail through. And let's hope for the Retinawesome 10. By that time, we are able to get rid of COVID.
Thank you very much, and I really appreciate everybody here. I really appreciate especially our staffs, our professors, Dr. Lam, to staying up late, because I know in Hong Kong it's probably midnight now, closing to midnight. Thank you very much, and I have to tell you always, and also the seniors like Athanasius and the other friends, we are always learning from you, and it's great honor to discuss. And André Jucá, you're still in the OR? You're operating?
Yes. Yeah, I'm going to begin some urgent surgeries here.
Okay, we are saying goodbye to people, and thank you very much, André Jucá, also our keynote speaker. Thank you for your cases, and I will flip the word if you want to say anything. Goodbye. Thank you very much.
Thank you very much for everybody, and it was very nice having you all together. I learned a lot today. And I will try to post the video here for some guys asked me some details about the technique that was perhaps, the video was perhaps a little too fast to see, and perhaps slowly. It's going to be nice. I will try to post on the Retinawesome WhatsApp group. Thank you very much, everybody.
Thank you.
Thank you, Andre.
Bye-bye, Athanasius. Bye-bye, Dr. Lam.
Thank you. Bye-bye.
See you.
Stay safe.
You too. Yeah. Safe trip back, as you said last time.
Safe trip back. Now it's just say stay safe. Stay at home.
Yeah, stay home. Yeah. We cannot.
No not nice trip back, but stay at home. Okay.
Okay. Bye-bye.